boom, boom, boom. Boom, boom, ti-boom, ti-boom, boom, boom. We will get there. Heaven knows how we will get there. We know we will get there. We are going. Heaven knows where we are going. But we know we will get there. Boom, boom, ti-boom, ti-boom, boom, boom. Boom, boom, ti-boom, ti-boom, boom, boom. It will be hard, we know, that the road will be muddy and rough, but we will get there. Heaven knows how we will get there. We know we will get there. Boom, boom, ti-boom, ti-boom, boom, boom. Boom, boom, ti-boom, ti-boom, boom, boom. It will be hard, we know, that the road will be muddy and rough, but we will get there. Heaven knows how we will get there. We know, we know, we will. We will get there. Heaven knows how we will get there, but we know we will. We are going. Heaven knows where we are going, but we know we will get there. We are going. Heaven knows where we are going, but we know we will get there. We are going. Heaven knows where we are going, but we know we will get there. Boom, boom, ti-boom, ti-boom, boom, boom. Boom, 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 boom. We will get there. Heaven knows how we will get there. We know we will get there. We are going. Heaven knows where we are going. But we know we will get there. Boom, 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 boom. Boom, 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 boom. It will be hard, we know, that the road will be muddy and rough, but we will get there. Heaven knows how we will get there. We know we will get there. Boom, 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 boom. Boom, 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 boom. It will be hard, we know, that the road will be muddy and rough, but we will get there. Heaven knows how we will get there. We know, we will. We will get there. Heaven knows how we will get there, but we know we will. We are going. Heaven knows where we are going, but we know we will get there. We are going. Heaven knows where we are going, but we know we will get there. We are going.
Tridem Pharma, a Fosun pharma company, acting as an expert interface between the pharmaceutical industry and the African and European market, like health authorities, wholesalers, prescribers and pharmacists. dedicate ourselves to provide efficient, secure, and traceable global supply chain solutions. With all-round recourse support by Fosun Pharma Group, we have set up an one-stop, end-to-end closed loop of pharmaceutical services, from access to delivery. A professional team handles drug registration, warehousing, distribution, and promotion activities. Regulatory support at every stage of a product's life cycle. End-to-end warehousing service including flexible storage, picking and packing, and real-time KPI reporting. The application of a MedLink intelligence system realizes the visual tracking of the whole process. Warehouse in Toulouse, France. Opened in March 2024. Support the special distribution of temperature-sensitive products, such as vaccines and biosimilar. A network of smart satellite warehouses, covering Côte d'Ivoire, Kenya, and other countries. A field team of 600+ experienced medical representatives, who are continuously trained on clients' products. Set up one-on-one meetings with physicians and pharmacists, and take orders on behalf of Tridem Pharma's clients. A multi-level system covering hospitals, pharmacies and wholesalers with administration and hosting support, localized compliance, finance and other services. Integration of industry resources has established strategic cooperation with more than 30 international pharmaceutical companies. In-depth partners of multiple international institutions. We have built an ecological network of the pharmaceutical industry covering commercial resources and public welfare actions, and promotes the efficient integration and sustainable development of medical resources.
Health is the eternal pursuit of mankind. At Fosun Pharma, we never stop innovating. Together, we're committed to creating better health for families worldwide. Founded in 1994, rooted in China and serving the world, Fosun Pharma is a leading innovation-driven global healthcare company. Guided by the strategy of innovation, internationalization, intelligentization, and integration, Fosun Pharma is committed to addressing unmet clinical needs through innovation, advancing the high-quality development of China's pharmaceutical industry, and contributing to global health. Innovation is the core driving force for Fosun Pharma's development. Backed by more than 30 years of exploration, Fosun Pharma has established an open and global innovation and R&D system. We are focusing on core therapeutic areas such as oncology and immunoinflammatory, and strengthening our antibody, ADC, cell therapy, and small molecules core technology platforms. Fosun Pharma has launched a number of breakthrough innovative products in the areas of breast cancer, lung cancer, hematologic malignancies, oncology support care, etc., and is actively expanding its pipeline in non-oncology and vaccine areas. In collaboration with industry firms, Fosun Pharma is investing in cutting-edge technologies, including radiopharmaceuticals, RNA, gene therapy, and AI drug discovery, continuously driving the development and commercialization of innovative technologies and products. Internationalization is a long-standing strategy and a core strength of Fosun Pharma. Fosun Pharma continues to execute on global strategy across R&D, licensing, manufacturing, and commercialization, striving to bring high-quality, innovative products to patients around the world. We continue to strengthen our global two-way licensing cooperation and expand the global market together with our partners. At the same time, leveraging our global presence, we introduce advanced technologies and products into China, accelerating localization and benefiting Chinese patients and customers. Since our founding over 30 years ago, Fosun Pharma has consistently upheld its original intention of contributing to society, actively embraced corporate social responsibility, and achieved remarkable ESG results. We support rural doctors and contribute China's solutions to the global fight against malaria. We care for rare disease patients and support innovation in China's life sciences sector. Looking forward, Fosun Pharma will continue to drive innovation and pursue global development with the ambition to become a leading global healthcare company to integrate the pharmaceutical and medical innovation, making greater contributions to human health. Innovation for good health.
Tridem Pharma, a Fosun Pharma company, acting as an expert interface between the pharmaceutical industry and the African and European market, like health authorities, wholesalers, prescribers, and pharmacists. Dedicate ourselves to provide efficient, secure, and traceable global supply chain solutions. With all-round recourse support by Fosun Pharma Group, we have set up an one-stop, end-to-end closed loop of pharmaceutical services, from access to delivery. A professional team handles drug registration, warehousing, distribution, and promotion activities. Regulatory support at every stage of a product's life cycle. End-to-end warehousing service including flexible storage, picking and packing, and real-time KPI reporting. The application of a MedLink intelligence system realizes the visual tracking of the whole process. Warehouse in Toulouse, France. Opened in March 2024. Support the special distribution of temperature-sensitive products, such as vaccines and biosimilar. A network of smart satellite warehouses, covering Côte d'Ivoire, Kenya, and other countries. A field team of 600+ experienced medical representatives, who are continuously trained on clients' products. Set up one-on-one meetings with physicians and pharmacists, and take orders on behalf of Tridem Pharma's clients. A multi-level system covering hospitals, pharmacies, and wholesalers with administration and hosting support, localized compliance, finance, and other services. Integration of industry resources has established strategic cooperation with more than 30 international pharmaceutical companies, in-depth partners of multiple international institutions. We have built an ecological network of the pharmaceutical industry covering commercial resources and public welfare actions, and promotes the efficient integration and sustainable development of medical resources. Tridem Pharma, a Fosun Pharma company.
Okay, I hope I'm loud and clear. Just gonna put in my presentation. Good morning, everyone. Sorry, good evening, everyone. Hope you're all good from wherever you're joining us from. Welcome to tonight's webinar titled Advancements in Anticoagulants, a focus on Rivaroxaban. We are thrilled to have you join us for this live CPD session, CPD accredited session, proudly brought to you by Tridem Pharma, a Fosun Pharma company. Anticoagulant therapies continue to evolve, and Rivaroxaban stands at the forefront of the innovation. Transformation, how we manage thromboembolic conditions across diverse clinical settings. Tonight, we'll explore its expanding role from cardiology to pulmonology and even orthopedic surgery. We are honored to be joined by an audience from Ghana and Tanzania, as well as 3 distinguished experts the continent. Starting with Dr. Francis Agekum, who's a consultant interventional cardiologist at the Cole Bull Teaching Hospital and senior lecturer at the University of Ghana Medical School, with a fellowship from both Ghana and West Africa Colleges of Physicians and advanced training in interventional cardiology. Dr. Agekum brings deep insights into anticoagulant use in cardiovascular care. Professor Jane Afriya-Mensah, Associate Professor of Internal and Respiratory Medicine, a consultant pulmonologist at the Corbu Teaching Hospital, a leading researcher in hospital complications and lung cancer. She offers a unique perspective on anticoagulants and in respiratory disease and comorbid conditions. And finally, of course, we have Dr. Mgisha, specialist orthopedic and trauma surgeon at Muhimbili Orthopedic Institute in Tanzania, adjunct lecturer MUHAS with subspecialty expertise in joint replacement and trauma care. Dr. Mugisha will share practical insights on anticoagulant use in surgical and post-operative settings. Together, they'll guide us through the latest evidence, clinical applications, and emerging trends in Rivaroxaban therapy. So I would encourage you to sit back. Let's all be ready and open our minds to sharing information, and let's dive in through this dynamic conversation. My name's Seth Oiti. I'm the marketing manager, Sub-Saharan Africa for Fosun Pharma, and tonight I'm privileged to be your proud moderator for the sessions which are going to take place in this webinar. How we will proceed, as you can see in your screen, we will start with Dr. Agekum, Dr. Agekum Francis, who's going to be taking us through anticoagulants therapy, epidemiology of clotting, and finally atrial fibrillation, with a focus, of course, on. And after that, the presentation will be followed by Dr. Professor Jane Afriya-Mensah, who's a pulmonologist, and she'll be taking us through pulmonary embolism with a focus. This presentation will be followed by Dr. Gisha Williams' presentation on Rivaroxaban in surgery. And then finally, after that, we'll proceed to the final part of the presentation, which will be an introduction to the Rivaroxaban from Fosun Pharma by the brand name Varosun. That being said, for the audience and participants in the sessions, I would encourage you to please feel free to are going through the chat box area, which you'll see on the platform, as well as the Q&A section, which again you can be able to see, and finally as well on the comment section. For the times which I've projected in the previous slide, these were more Tanzanian time, so they probably will be worked 3 hours back to project the Ghanaian times on the screen. So that's something which I also wanted to check. And for the Tanzanian doctors, please, as you probably join and continue participating, make sure you comment or you type in your name and say, I'm Dr. So-and-so from Tanzania, so that we are able to capture this and give you a particular recognition from the country you come from. That being said, I think I would like to dive straight into the session and introduce our first speaker for the session. I'll just give a brief introduction of the first speaker for the session, Dr. Francis Agekum. Dr. Francis Agekum is a consultant cardiologist, like I've mentioned, from the Kolbu Teaching Hospital and a senior lecturer at the University of Ghana Medical School. He's a fellow of both Ghana and West African Colleges of Physicians. He also holds an advanced qualification in preventive cardiovascular medicine from the University of South Wales and interventional cardiology from Guangdong Cardiovascular Institute. With over 2 decades of clinical experience across Ghana, Dr. Agekum has led pioneering work in cardiovascular care including coronary interventions and heart failure management. His research spans hypertension, coronary artery disease, stroke, cardiovascular disease prevention, cardiology, and is affiliated with the global organizations such as American Heart Association and the European Society of Cardiology. Dr. Agyekum is a frequent speaker in international conferences and a driving force in shaping cardiovascular health policy education in Ghana. That being said, Dr. Agyekum, welcome, and take us through advances in anticoagulants, a focus on Rivaroxaban, particularly with emphasis on atrial fibrillation. Dr. Agyekum.
Hello, can you hear me?
Loud and clear.
All right, good. Okay, good. Good evening to you all, and thank you for the kind and generous presentation introduction. So my duty is simple and straightforward to look at advances in anticoagulation in atrial fibrillation. Our focus is on Rivaroxaban, as has been said, the use of Rivaroxaban in atrial fibrillation. So I'm going to give a brief introduction of atrial fibrillation, the main cardinal points in the management of atrial fibrillation, and then spend a bit more time on the anticoagulation in atrial fibrillation. So as we know, atrial fibrillation is an abnormal rhythm that's usually a supraventricular tachyarrhythmia. It's uncoordinated atrial activation, and it comes with a lot of consequences. And how to recognize atrial fibrillation on your ECG is that usually, your RR interval is irregular, and then you also have no distinct P waves. You actually see fibrillary waves or waves that are not clear P waves. So it may either be fine or cause atrial fibrillation. So this is an example of that. I don't know whether you can see my pointer, but the first one on your left shows a very regular beating with a clear P wave and KRS complex and T wave, whereas the second one, you just see some wavy baseline, no clear P waves. The RR intervals are irregular. The R's are different in height. So this is a clear indication of atrial fibrillation by way of 12-lead ECG. So this is an example of a patient who has atrial fibrillation. So if you look at the rhythm strip, and you could take any of the rhythm strips, either vein 1 or lead 2 or vein 5, you can see that the RR intervals are irregular. Also, the height of the R waves are different. You do not see any clear P wave that is preceding the KRS complex, and then you have this wavy baseline. So this is a clear indication of atrial fibrillation. So this, we can see atrial fibrillation with pretty, normal heart rate compared to this one that shows atrial fibrillation with a very fast ventricular rate. So it is not every atrial fibrillation that comes with fast ventricular rate, but the cardinal principles are still the same. Look at the RR intervals, look at whether you are seeing clear P waves or whether you are seeing fibrillary waves to make the diagnosis of atrial fibrillation. It is a very prevalent condition, at least as indicated by the atria study that showed that among the US population, about 1% had atrial fibrillation. Indeed, now current estimate is that about 2.9% of the global population has atrial fibrillation. The prevalence depends on where you stay, depends on your age, depends on your other risk factors, for instance. So if you take people who are, let's say, below 55 years, you are going to have atrial fibrillation prevalence of under 1%. Compared to people who are about 80 years, you have atrial fibrillation prevalence of close to 10%. So depending on the risk factors that are prevailing, the prevalence also differs. And that is also well demonstrated in this graph as well. So atrial fibrillation is the most common sustained cardiac arrhythmia in clinical practice. And all of us will see it either at the clinic, either in the emergency room, on the wards, or sometimes it's just pick up during screening. And you need to be able to identify the presence of atrial fibrillation. And as I said, the global prevalence depends on it's not the same, depends on the locality and other things. Another important thing we need to remember is that atrial fibrillation is not a benign condition. It is associated with increased risk of stroke, increased risk of heart failure, increased risk of mortality. Indeed, it is an independent risk factor for stroke, and approximately 5-fold increased risk in stroke. So people who have atrial fibrillation are at 5 times increased risk of developing stroke than those who do not have. It is said that 1 in every 6 strokes occur in patients who have atrial fibrillation. And that is why it is important to be able to identify it and prevent stroke. If you do not prevent stroke, then identification doesn't really matter. And another thing is that people who develop stroke as a result of atrial fibrillation, their outcome is worse than people who do not have atrial fibrillation. And this is partly due to the presence of the atrial fibrillation itself and also other comorbidities that are associated with the atrial fibrillation. Another important thing that we need to remember is that, as I said, it's an increased risk of mortality associated with 2-fold increased risk in mortality, and also an independent risk factor for heart failure, in addition to death, stroke, failure. Atrial fibrillation is also associated with cognitive decline, depression, impaired quality of life, and more frequent hospitalizations. These are all things that we need to be able to prevent when we are managing patients with suspected atrial fibrillation. Traditionally, atrial fibrillation has been classified as first onset atrial fibrillation, paroxysmal atrial fibrillation, those kind of things. There were other forms of classification like valvular atrial fibrillation, non-valvular atrial fibrillation. Now, the more current way of classifying atrial fibrillation is to be more proactive and pragmatic, so that we can identify the risk factors that are predisposing the patient to atrial fibrillation. So just like we did for heart failure, people who are at risk of developing atrial fibrillation are classified as stage 1. So these are people who have risk factors. It could be modifiable or non-modifiable risk factors that are known to be associated with atrial fibrillation, such as obesity, hypertension, sleep apnea, diabetes, alcohol abuse. All these are risk factors that are associated with atrial fibrillation. The import, if you identify these risk factors and you manage them well, you will be able to prevent them from developing actual atrial fibrillation. So then the is those who have what we call pre-AF. So in addition to the risk factors, they have structural or electrical abnormality of the heart that is known to predispose people to atrial fibrillation. So, for instance, if a hypertensive patient has left atrial dilatation or left ventricular hypertrophy with increased pressures in the left atrium, these people are at increased risk of developing atrial fibrillation. So they are said to be pre-atrial fibrillation. If you have a patient hypertensive who has frequent atrial ectopics, that patient is also at increased risk. So it's said to be pre-atrial fibrillation. Then you come to the actual AF, where you then have paroxysmal AF, AF that is intermittent and terminates within 7 days, but terminate doesn't mean that it doesn't come again. It might come again, and therefore it is as serious as persistent AF or long-standing AF. So persistent than 7 days, and then when you say long-standing persistent stays for more than 1 year, and then we can also have AF which has been successfully ablated, or AF, permanent AF, where both the clinician and the patient have come to the decision that no further efforts are going to be made to convert that patient into nurse rhythm. So these are some of the definitions that are provided by the guidelines. So I think I've mentioned all of them. First diagnosed AF, paroxysmal AF, persistent AF, and permanent AF. I have actually mentioned all of them. Other terminologies: device detected AF. So AF is when you have actually confirmed presence of AF with a 12-lead ECG, or in the absence of a ECG, the patient did a Holter, a prolonged Holter, and you have at least 30-second segment showing AF, then you can say clinical AF. It does not matter whether the person has symptoms or not. It could be symptomatic AF or asymptomatic AF. Then we have what we call device detected AF. These are the subclinical AFs. With the modern use of gadgets like the Apple Watch and so many other devices that are able to check rhythm, patients may have episodes of fast atrial beat, and that may be an indication of AF, but you need to be able to confirm the presence of AF with your 12-lead ECG. The other important aspect of AF is what we term as AF burden. So the burden of AF is the overall time that a patient spends in a 12-lead hour halt. Is the patient in AF throughout the 24-hour period, or about 50% of the time the person is in AF, or 25% of the time the person is in AF? That is into AF burden. I think I've mentioned the risk factors with AF. We have the non-modifiable risk factors and the modifiable risk factors. So your evaluation of patients with AF, you need to be able to identify which risk factors are present, because management of risk factors is an important aspect of your AF management. Don't forget, hypertension, diabetes, COPD, all of them are risk factors that are associated with AF, and you need to manage them well as well. I know many people don't like pathophysiology, and I'm not going to spend time on this, but just to mention that the AF pathogenesis is not completely understood, and factorial, genetic factors, non-genetic factors all play a role in the pathogenesis of AF. So risk factors typically will cause cardiac structural physiologic changes that lead to atrial remodeling. This atrial remodeling involves cellular hypertrophy, of fibroblasts leading to fibrosis, and then alterations in the ion channel functioning, calcium homeostasis, and all these are important aspects leading to what we term as atrial removal. That's an important for AF generation perpetuation. There are several things that play. Theory proposed. One of them is the pole weight theory. Because of the heterogeneous nature of the atrium, several foci are producing the AF, and the abnormal atrium is serving as a substrate to perpetuate the AF. So it could be re-entry phenomena and other mechanisms that are at play. There's also this trigger and substrate theory, where, and it's quite similar. AF and that trigger could be a rapid firing focus. Substrate is an abnormal left atrium to maintain it. So some of the triggers, most will be around the pulmonary veins, near the ostium of the pulmonary veins, but you could also have it anywhere, like superior vena cava, posterior left atrium, coronary. For maintaining the of it's an abnormal induction delays. And one thing we need to remember is that AF itself results in both anatomic and electrophysiological modeling of the left atrium that contributes to the persistence of AF. So sometimes patients may start with paroxysmal AF, but the mere presence of the AF itself may lead to abnormalities in the atrium that will later lead to persistent AF and then eventually permanent AF. As I indicated earlier on, patients with AF may be symptomatic or asymptomatic. Sometimes they are picked up during clinical examination, routine clinical examination, or routine laboratory investigation. Has gotten a job, needs to do evaluation done, and then you pick up the AF. That is clinical AF, despite the fact that the person does not have symptoms. Or sometimes patients may come to you at the clinic or in the emergency room as a result of palpitations, dyspnea, fatigue, or symptoms of heart failure. Or sometimes they may be hemodynamically unstable, and then you pick this AF up. So it depends on the scenario, and it can present. I just want to emphasize that once your 12-lead ECG documents AF, it is clinical AF. If you do not have a 12-lead ECG and you just have Apple Watch or any other smartwatch or device indicating the presence of AF, you need to have it documented either by 12-lead ECG or by a Holter monitor that shows at least 30 seconds recording of AF before you can conclude that this patient has clinical AF. So having given this background to AF, what it is, epidemiology, diagnosis, let's zoom into the management, and then we bring it to a close. I just want to give you an overview of AF management so that even if you don't finish, at least you have the main cardinal points when it comes to AF management. And the management of AF is focused on controlling the symptoms. Patient has symptoms or not. If the patient has symptoms, you need to control. And this controlling of symptoms, control or rhythm control. is leading to the symptoms. So you may either control the heart rate or control the rhythm. Optimizing the modifier risk factors that are present. As for the non-modifiable, you can't do much, but modifiable risk factors manage hypertension, sleep apnea. So any risk factor, manage them well and prevent thrombosis and thromboembolic events. And that is one of the main problems associated with AF. So you want to prevent stroke, and we will talk much about that. And the fourth point is that engage the patient in a shared decision making. You do not manage all AF the same. The patient also has a say as what they like. Do they want rate control? Do they want rhythm control? Even when it comes to anticoagulation, they still have a choice. So it is important that the patient is carried along, especially patient who does not have symptoms of AF. And you tell the person that you are going to take this blood thinner with a potential of bleeding for the rest of your life. You need the patient's buy-in to be able to have a successful management of this patient. So this is the overview of the management of AF. And remember, rate and rhythm control strategies in AF are reported to result in similar reductions in symptom severity, mortality, and thromboembolic events. So in my case, we will do a rate control, but if the patient prefers a rhythm control, why not? It could be the first choice. Or if you tried rate control and it did not work, patient is still symptomatic, you then have to do a rhythm control. This is a very complicated matter that I have simplified like that, so I know people can have issues with that. And this is consistent with what the European Society of Cardiology put up. They termed it AF care. So the 4 cardinal measures, and that includes which health cadre are involved in the management of AF. So, and it involves everybody. So C is for comorbidity and risk factor management. So lifestyle help, primary care, cardiology, internal medicine, nursing care, all of them are involved in achieving this comorbidity management. A is avoiding stroke and thromboembolism, and all of them are still involved. The neurologist is involved, the cardiologist is involved, the nursing, anticoagulation, very important. The R is reduction of symptoms, and this is where you consider rate versus rhythm control. And E is further evaluation and then dynamic reassessment. So you evaluate your patient. It's not a one-time off something. You continue to evaluate what is the risk of bleeding. Has the patient tolerated your medication well? Has there been any changes in the patient's desire and all those things? And that is similar to what the Americans also put up in 2023. So the pillars of AF management, they christened it for, and it's the same thing: stroke optimization of all these are together, and the guidelines are consistent in trying to help us understand. And if you look at the bottom, they have put all the risk factors that one needs to consider and help address them as well. So how do you control the rate when it comes to AF? There are several agents for rate control. As I said, it is often the initial strategy for asymptomatic patients, particularly if the AF is long-standing, and then you attempt to maintain sinus rhythm will come in with the rate control fails, or the patient has not had persistent AF, for more than 1 year, a lot of the time we try to see if we can convert them to sinus rhythm as well. Beta blockers are good rate control agents. Non-dihydropyridine calcium channel blockers like verapamil, diltiazem are good as well. Digoxin, amiodarone, and then sometimes you can ablate and pace for rate control. Remember, amiodarone functions as both rate and rhythm control, so it's important that sometimes you shouldn't be surprised when you try to do that and you can convert them to sinus rhythm. Also, you need to assess the response of the patient when you are doing rate control. There is this issue of tight rate control versus lenient or liberal rate control. I mean, majority of the time, or most of the time, if you're able to keep their rate at resting heart rate at below 110 beats per minute, they are less symptomatic. But if at that point they are still symptomatic, you can try and bring their rate to about below 80 beats per minute, and that also helps to improve their quality of life. What about rhythm control? There are several drugs that are available for rhythm control. Flecainide, propafenone, as I mentioned, amiodarone can also be used for rhythm control. Ibutylide. You can also use electricity to control the rhythm, especially if the patient is hemodynamically unstable. In that case, electrical cardioversion is very, very useful. And then, of course, catheter ablation is one of the very often sought after modalities for rhythm control. So that is also important as well. What are the factors that favor rhythm control? If the patient is young, most of the time we prefer rhythm control. If it's the first AF episode and a short history, you tend to prefer rhythm control. AF precipitated by a temporary event, if it's persistent, you can consider rhythm control. Of course, if the patient has tachycardia-induced cardiomyopathy, we tend to prefer that. If the person has paroxysmal atrial fibrillation, you tend to prefer rhythm control. So you consider the patient in totality. Of course, if the left atrium is not so huge, because if the left atrium is so dilated and you go and do rhythm control, they are most likely to return to atrial fibrillation. So these patients, if they are not symptomatic with rate control, there is no need to push for rhythm control. And this is one of the guidelines. Cardioversion in atrial fibrillation, usually for patients who have hemodynamic instability. When they come, atrial fibrillation, fast ventricular rate, hemodynamic instability, cardioversion is the way to go. Sometimes for patients who are not hemodynamically compromised, they are stable, you can still consider cardioversion. But in that case, if the atrial fibrillation has been there for more than 48 hours, you need to make sure that they are well anticoagulated. Otherwise, converting the atrial fibrillation to sinus rhythm leads to clot formation that may also lead to thromboembolic stroke and other things. So it's important that you anticoagulate them for a minimum of about 3 weeks before you do the cardioversion, or if is within that period, you can do transesophageal echo. You do transesophageal echo, look at the left atrial appendage to see if there's no clot in the left atrial appendage. Then you can go ahead with your cardioversion. Now, let me spend the rest of the time to look at anticoagulation in atrial fibrillation, and we bring it to a close. We traditionally know how to assess the risk, and the risk is very, very important. You need to assess the risk of bleeding and the risk of thrombosis or stroke. And more traditional one that has been used over the years is the CHAD-VAS score. More recently, it's been changed to CHAD-VA. So the sex component has been taken out. So this one shows the more modern one where I think all of us know them. So chronic heart failure gives you a score of 1, hypertension, a score of 1, age more than 75 years, give you a score of 2. The same way if you had a TIA or a prior stroke, it gives you a score of 2. So the sex component is what has been taken out. Once you are using the CHAD differentiation in the value for decision making, whether especially when it comes to CHAD-VAS score of 1 or 2, there is no differentiation in terms of male versus female. And so that is the more modern one that we tend to use. What strategy should you use in your anticoagulation? And I make this bold statement here that NOACs, or the novel oral anticoagulants, the DOACs, are preferred over VKA for stroke prevention. VKA are the vitamin K dependent anticoagulants like warfarin, the coumarins. So the DOACs, direct oral anticoagulants, are preferred over the VKAs, except in mechanical valves and moderate to severe mitral stenosis. And this is regardless of the CHAD-VAS score. So in majority of your patients, they are going to benefit from the direct oral anticoagulants. For patients who have CHAD-VAS score of 2 or more, there is no controversy when it comes to the need for anticoagulation. In terms of CHAD-VAS score of 1, then the decision comes. The recommendation is moderate recommendation. So majority of cardiologists will anticoagulate patients who have a CHAD-VAS score of 1. You also need to look at the Hasbled score. And I must say here that the Hasbled score is not to make you stop anticoagulating, but to help you to determine what factors are increasing the person's risk of bleeding and try to address those factors. So if the blood pressure is not well controlled, you need to address that. If the patient has medications that are going to affect their coagulation pathway, you need to address that. So the role of the Hasbled score is to help you identify what are the factors that are increasing my patient's risk of bleeding. So what are the properties of an ideal anticoagulant? For something that is going to be used for lifelong, oral administration is preferred. It must be convenient use both in and out of hospital. You can imagine if you have to come to the hospital to be injecting yourself every day, or if you can inject in the house. Even people are afraid of injection. So oral administration, if it can be done, is preferred. If that medication has a wide therapeutic window so that little mistakes from patients may not be disastrous, it's low risk of food and drug interactions is a key aspect of an ideal anticoagulant, because people don't eat the same foods and the same substances all the time. Their food may change. And if that agent is interacting with food, is interacting with other medications, your atrial fibrillation patients tend to have a lot of many comorbidities. They are likely to have many other medications they are taking and that drug interaction. So if you have an anticoagulant that minimal interaction with other medications, that is important. If the effect is predictable, that it gives you a safe and effective regulation of your anticoagulation throughout the therapy, and that is important. If that's, you don't need to be taking blood samples and monitoring all the time. That is also an added advantage for that ideal anticoagulant. And if the dosing regimen is very simple, then that is also an. These are the properties of an ideal anticoagulant. And you agree with me that when you look at the traditional anticoagulant that we had, they have drawbacks. If you take unfractionated heparin, for instance, it needs to be administered by injection. You need to adjust the doses every now and then. The risk of heparin-induced thrombocytopenia is there. Low molecular weight heparins, parenteral administration, you need to adjust the dose by weight. Oral vitamin K antagonists, narrow therapeutic window. And so the risk of bleeding, fatal bleeding is also there. Interaction with food and drugs is massive because of the cytochrome P450 enzyme. So there's a lot of interaction. You have to tell your patients, don't eat this, don't eat that. Patients really struggle to stay on it. And no wonder time in therapeutic range becomes a challenge in patients who are taking vitamin K antagonists. Indeed, this just elaborates the problems. Significant drug-drug interaction, narrow therapeutic window, and so patients' time in therapeutic range is often compromised. And there are agents that affect other factors in the coagulation pathway that give us good anticoagulation without all these limitations. The factor 2, that's the direct thrombin inhibitor. The main agent that is available for oral administration is dabigatran. Then the factor 10, direct factor 10 inhibitors, Rivaroxaban, Napizaban, Nedozaban, and the Bestrizaban. So these are the agents that are available for oral anticoagulation. And you agree with me that they tend to have benefits over the vitamin K antagonists. Their onset of action is fast, reduced potential for food and drug interactions, predictable anticoagulation, simplified fixed dose regimen, and no need for routine coagulation monitoring. So with this, you are able to reduce the administrative costs. You don't need to be checking medication, blood levels all the time. You improve the quality of life of the patient and then improve benefit profile. And now, I mean, when these agents came initially, the main disadvantage was the cost. Now, with the generics available and the cost profile, I find it difficult to see if any cost argument can be made against the use of this direct oral anticoagulants. Several trials have been done in respect to their use, and compared with warfarin, they are not inferior to warfarin when it comes to the side effect profile. In fact, some of the studies have actually shown that they are better than warfarin. And I'm sure you are aware of all these trials that have been done. The Rely trial, the Reliable trial, all these for dabigatran, and then the Rocket AF trial that was for Rivaroxaban, Aristotle trial for Pizaban, and then Engage AF Timmy for Edozaban. So several trials have been done, and all these trials have shown that in some cases these drugs are even better than warfarin, but in all those cases they are non-inferior to the warfarin. These trials, some of them have different patient characteristics that were included. You look at this and you see that with respect to the Rocket AF trial, you have quite a number of variables that the patients have. So it gives us room to be able to look at other patient characteristics as well. 91% of them had hypertension, chronic heart failure, 62% of them had it. If you look at the Achad score, 3.5 versus 2 point distance. So it's these patients are high risk patients as well, and so to be able to test this against this medication, then that is a very important aspect. And Rivaroxaban was the first oral direct factor 10 inhibitor that was identified. It's a specific competitive factor 10 inhibitor, inhibits free and fibrin-bound factor 10 activity and prothrombinase activity. It also inhibits thrombin generation, and there's no direct effect on the thrombin-induced platelet aggregation, and it has a bioavailability of 80 to 100%. So if you look at the Rivaroxaban profile, you see that it has quite a rapid onset of action if you compare that with the enoxaparin as well. So you do not need to medicate your patient with heparin before you can start them on Rivaroxaban. It has a pretty fast, rapid onset of action. So let me take a few minutes of yours to look at the Rocket AF trial. That was a prospectively tested a prospective study that tested the reduced dose in AF patients with renal impairment and also other patients. So for those who had renal impairment, they used 15 milligrams once daily. And for those who did not have renal impairment, they used 20 milligrams once daily. And the outcomes were, as I've already stated, they were non-inferior to warfarin. So Rivaroxaban, in whether you have renal impairment or you don't have, they were non-inferior to warfarin therapy. So they can still be used. And if you look at the side effects, significant reduction of critical organ, intracranial hemorrhage, and fatal bleeding versus warfarin, they were reduced, relative risk reduction in these things. So conclusion is that there were no significant increased rates of bleeding. Actually, the bleeding rates, if you look at most of them, were lower in the Rivaroxaban group than in the warfarin group. And as I said, consistent benefit across different comorbidities for challenging AF patients. So if you have AF patients with hypertension, elderly AF patients more than 75 years, that is another aspect that many people have questions. Can you use them for patients who are, say, 80 years with AF? Yes, these medications can be used. They had patients that were included in these trials as well, and they did not show any increase bleeding rate. So you have Rivaroxaban effective in elderly AF patients who are more than 75 years. Not trying to bore you with all the details. About 6,229 patients were aged 75 years and above. And the conclusion was that results support use of Rivaroxaban as an effective alternative to warfarin for stroke prevention in both young and elderly patients with AF. So these medications can still be used in patients who are above 75 years. How about those who have moderate renal impairment? I've mentioned that already, that results support use of Rivaroxaban as an effective alternative to warfarin for stroke prevention in patients with moderate renal impairment as well. But this time, you are going to use a reduced dose of 15 milligrams once a day, not the usual 20 milligrams once a day. So conclusions from the Rocket AF study is that based on the pre-specified primary efficacy outcome, a once daily fixed dose regimen of Rivaroxaban was non-inferior superior to warfarin for prevention of stroke or non-CNS systemic embolism. Rivaroxaban was superior to warfarin while patients were taking steady drug. A sensitivity analysis in the intention to treat population that followed all patients in the trial until completion suggested the benefit of Rivaroxaban, but did not reach superiority. Then when it comes to safety, the same statements we have made previously, that Rivaroxaban are safe as warfarin as well. When it comes to the implications, you can use Rivaroxaban in a wide variety of patients. I look at this study that was published in the BMC Neurology, safety and effectiveness of Rivaroxaban, dabigatran, and apixaban in patients with non-valvular atrial fibrillation for stroke. So they look at all these medications in various patients. The conclusion was that among all drugs, there was no significant differences in the rates of stroke. So it is important that we know all these drugs, whether dabigatran, Rivaroxaban, apixaban, edoxaban, they can all be used to prevent a stroke in atrial fibrillation. And now you have a variety of them, many of them in generic forms. So I started to think how many of your patients should still be on warfarin. So I'm coming to my the end of my presentation. I'm trying to give a summary of anticoagulation in atrial fibrillation, and that will bring us to a close. So the treatment must be based on the risks of your patient. Use long-term oral anticoagulation over antiplatelet therapy or no therapy for patients with high risk for stroke based on the CHAD-VAS score or now the CHAD-VA score. So if you are still using the CHAD-VAS score, then if your CHAD-VAS score is 2 or more in males or 3 or more in females, that patient needs long-term oral anticoagulant therapy. If you are using the CHAD-VAS score, if it is more than 2, they need oral anticoagulant therapy, and this is a strong recommendation. If that patient has moderate to severe mitral stenosis, you need you need anticoagulation therapy for that patient. If that patient has hypertrophic cardiomyopathy or cardiac amyloidosis, together with the atrial fibrillation, that person, you just need to start them on anticoagulant therapy. For patients with CHAD-VAS of 1, females or of in getting long, this is a moderate recommendation. So remember, the first one we are looking at 2, that's a strong recommendation, and then 1 is a moderate recommendation. And then the type of anticoagulant therapy, use drugs over warfarin for patients with AF requiring anticoagulation, excluding those with valvular heart disease or mechanical heart valve. So the 2 circumstances where you will be forced to use your VKAs if the patient has valvular atrial fibrillation, moderate to severe mitral stenosis or rheumatic valve disease or mechanical valve, then these VKAs over the drugs. And I've mentioned the examples. Use warfarin over drugs for patients with AF and any of the following conditions: moderate severe mitral, rheumatic mitral stenosis, mechanical prosthesis. Consider warfarin with an INR target of 2 to 3 or apixaban for patients who are on dialysis or who have end-stage renal disease. And this more important, do not give antiplatelet therapy in place of anticoagulation. They are different. I have seen it too many times that I just had to put in there. Anticoagulant therapy is different from antiplatelet therapy. So do not give antiplatelet therapy in place of anticoagulation or in addition to anticoagulation for the purpose of preventing ischemic stroke and thromboembolism patient infarction who are had PCI down, it is a high risk, both thrombosis, bleeding, and especially should be managing these patients. Sometimes we do triple antithrombotic therapy for about a week, then we scale down to dual antithrombotic therapy for a year, and then we come down to anticoagulants. So my final summary, atrial fibrillation is a very common cardiac with high consequences. Accurate diagnosis is based on 12-lead ECG or ambulatory ECG monitoring. The AF care plan is a comprehensive way of managing a patient with AF. It looks at all aspects of it, the symptom management, the risk factor management, preventing stroke, and you need to be abreast of this to be able to have a holistic management of your patient. The drugs, that the direct oral anticoagulants, and in this case, our focus is on Rivaroxaban, have emerged as the preferred anticoagulant agent in many patients with non-valvular atrial fibrillation. And these days, cost is no longer an excuse not to use these medications. Thank you very much.
Thank you very much, Dr. Agekum. Presentation well executed. Checking with my, yeah, now I can be able to see. Thank you very much. Presentation well executed. I think it was quite a very, very nice talk you've given. Once again, thank you. And I think quite a lot of insights into atrial fibrillation and its management have been obtained, starting from the description as you started your presentation, walking us through the epidemiology, diagnosis, and its management. And particularly on the management part where, as you had mentioned earlier, it's quite key to get the buy-in of the patient, especially in the asymptomatic AF patient. I think it was quite a profound part and part of the discussion, and of course a very important point for discussions for doctors managing AFib with the patients, and of course by extension to all patients receiving chronic medication. I think it's quite important to get the buy-in of the patient to walk with the patient through the journey to make sure they get the buy-in to take the medication for a prolonged period of time, if not with a particular endpoint in terms of stoppage. So thank you once again, Dr. Agekum. I would then kindly request you to stay on. We have an excellent opportunity to have the Q&A section where we'd request you to be able to address some of the questions being raised by our audience in the meeting. And to our audience, both from Kenya and Tanzania, from Ghana and Tanzania, please keep posting your questions in the Q&A section or the comment section, or as well in the chat box section. And during the Q&A section, we'll be able to address all these questions. So thank you very much, Dr. Agekum. That being said, this leads us to the next part of our session, where we'll be inviting our next speaker. Our next speaker for the session is Professor Jane Afriyie-Mensah. Professor Jane Afriyie-Mensah is an associate professor of internal and respiratory medicine at the University of Ghana Medical School and a consultant pulmonologist at the Kole Bu Teaching Hospital. With over two decades of clinical experience, she has become a leading voice in respiratory medicine in Ghana and sub-Saharan Africa. Her subspecialty expertise spans asthma, tuberculosis, pulmonary infections, and lung cancer, with a growing focus in improving lung cancer diagnosis and care in resource-limited settings. Professor Afriyie-Mensah has led pioneering research on pulmonary complications in sickle cell disease, tuberculosis comorbidities, and chronic pulmonary aspergillosis. She served as a site principal investigator for the US-funded whole genome sequencing study in Mycobacterium tuberculosis and currently chairs the Ghana's first multidisciplinary lung cancer team. Her academic contributions include over 25 peer-reviewed publications and leadership in national and international collaborations. She is the president of the Ghana Thoracic Society, a fellow of the Western African College of Physicians and the Ghana College of Physicians and Surgeons, and a member of the global organizations, including the British Thoracic Society, WABIP, and IASLC. Through her clinical, academic, and administrative roles, Professor Afriye Mensah continues to shape respiratory policy, education, and research across Africa. Once again, a warm welcome, Professor Afriye Mensah.
Okay, thank you very much, Seth, for the kind words. I would like to say good evening to our online viewers, and I want to remind us that the focus is still on Rivaroxaban. The lens is slightly moving to another topic, and that is pulmonary embolism. A moment whilst I share my slide. Yes, so that can be seen. So I think without wasting much time, I would start talking about pulmonary embolism with a focus on Rivaroxaban. I want to thank the first speaker for doing justice to Rivaroxaban as far as atrial fibrillation is concerned. Okay, so here we are. So pulmonary embolism is quite a familiar topic. We know that it is a life-threatening condition. There are two forms of venous thromboembolisms, which is the VTE. We have a PE or a DVT. Both are related in one way or the other, although one can exist without finding any evidence of the other. Now, for PE, we know that most of it is diagnosed, especially the fatal ones. Autopsy reports have shown that about more than half of them are diagnosed during an autopsy. That means that clinically we either miss them or these are patients who die suddenly. We know the symptoms of pulmonary embolism and they are varied, and so we'll not necessarily dwell on them. We have the acute presentation and the subacute presentation. They are not, the only difference between the two is it has to do with the time of onset. But in terms of management, it is not different. It is the most undiagnosed cause of death clinically, and more than 75% of them may have identified risk factors. And that is by some pathology reports or autopsy reports that were done many years back. There was a registry in the US that looked at how terrible is pulmonary embolism, and the 7-day all-cause mortality was 2.6 versus the 30-day that was much higher to 5.9. That means that the first month of having a PE diagnosis can be quite dangerous, and one must always look out for their patients to look for signs of deterioration and then manage them appropriately. Now, data in Europe said that 8 to 13 deaths in 1,000 patients for women would have died from pulmonary embolism, and a less figure 2 to 7 in men. It does not necessarily mean that PE is much common amongst women compared to men. I think there are studies to prove that gender per se does not increase one to the risk of getting pulmonary embolism. And that was actually looked at in a study by Barco et al. Okay, we want to also talk about maybe a brief discussion, but not necessarily to go into the pathophysiology. We all do know about the risk factors, how Virchow's triad, we need to have homeostasis. Without homeostasis, one factor gets more prominent and it predisposes the patient to having pulmonary embolism. It is basically a dislodged thrombus that settles within the pulmonary arteries. Now, the pulmonary artery starts from the trunk all the way down to the arterioles and then even to the capillaries. So anywhere that these clots will settle would constitute the diagnosis of a pulmonary embolism. It depends on the size. Bigger thrombi would normally settle in the major vessels, while smaller ones would dissipate and move downwards. We also know from studies that most of these come from the veins of the lower limbs and the pelvis. Now, there have been some literature on PEs or thrombi coming from the cardiac chambers, and that puts a rate to about 14 to 18%. The previous 90%, these are old studies, and one seeks to know exactly what they use, but most of them were autopsy findings. So there are some publications that have put the cardiac chambers being contributors to pulmonary embolism as 14 to 18%. Rarely we find them coming from the IVC itself. It's a big vein, and mostly we don't expect that would have thrombi in there. But there are some publications that have linked the thrombi source to IVC, particularly in patients with pancreatitis. I also came across, whilst I was reading, some very naughty sites of thrombi, and I was surprised. There was a publication by El Hamadi et al. That said they found the thrombi in the periprostatic venous sites and then the paravaginal veins. And I said, oh, this must have been a very detailed autopsy that was done. And then also, many have said that if you don't find anything in the lower limbs, then possibly, was it just a clot in transition? And also, we have found that our patients who are critically ill in ICUs, a thrombi may develop at the tip of an indwelling central line. I also want to draw attention to what we call the in situ thrombosis within the pulmonary arteries. So this is where the thrombi is not coming from the distal veins, but is actually forming within the pulmonary arteries. The name for that is pulmonary artery thrombosis, or what they call the non-embolic pulmonary thrombosis. So that is not necessarily PE, but clinically it becomes very difficult. And then we normally would lump them all together as pulmonary embolism. Now, the risk factors may be different for the in situ. That one would focus more on the vascular endothelial injury, and therefore conditions that predisposes patient to that would be the reason for the in situ thrombosis. Now, there was a study that sought to look at where are the origins of these emboli, because we always have thought that it is from the lower limbs, but sometimes clinically we can testify that we would look for sources and we will not find it. So they use this total body magnetic resonance direct imaging to try and locate the thrombi in patients who have PE. They had 99 patients in question and subjected them to these MRI scans. And it was surprising that over half of them, they did not find the source of the thrombus. There was no thrombus identified apart from the emboli that was in the pulmonary arteries. So they proposed from that study that is it possible that these are coming from the cardiac? They are also de novo, which is the part that I spoke about. And then they may also have been the whole thrombus lifting from the lower limbs and moving towards the lung, and therefore you would have no evidence. But some of these patients, interestingly, also had Doppler ultrasound that did not necessarily locate the DVT or the thrombus in the veins. And so the conclusion was that, is this Doppler ultrasound conclusive enough? No matter how we think about it, once we find the artery, when we find the clot in the artery, then we are treating pulmonary embolism. We are familiar with this. This is just a CTPA that is showing clots present within. On the first picture, you have the clot present in the right pulmonary artery, and then in the second picture, you have what we describe as the saddle embolism. And this one is a slim one. If it's a big one, yes, it may occlude it totally. And these patients, we would not be able to have clinical diagnosis except for autopsy. So we all do know the risk factors for PE. We're familiar with them. We know the situations regarding the Virchow's triad, immobility, the risk of having a pulmonary atrial fibrillation. Dr. Ejekum has said that, hypercoagulable states, having malignancies, etc., etc., etc. And so whenever we have these predisposing factors in a patient, then there's also the likelihood that they're at risk of developing pulmonary embolism. I don't want to overlook the genetic factors as well. And so based on risk factors, we also have had discussions about some definitions, provoked versus unprovoked PEs. When we say provoked, it means that risk factors are identified. Unprovoked means we do not identify or can readily know what the risk factors are. There was a study that was done by Stoiver et al., and they looked at 331 cases. Amongst their patients, they realized that 67% of them were provoked. If you look at the Einstein PE trial that was done in 2012, they also realized that 65% of their patients rather had unprovoked. So it depends on the population that one is studying, and the prevalence of whether provoked or unprovoked will vary. Now, we want to talk about briefly, how do we diagnose PE? We always diagnose PE starting with the clinical predictive score. And what we know, tested and validated, is the Wells score. Now, we have the original Wells score, and then we have the simplified Wells score. The only difference between the two is that the original one actually stratifies the probability of having a PE in a three-tier manner. So you have the low risk, the intermediate risk, and then the high risk. Whilst this is good or easy to assimilate, it's difficult to use this three-tier in a busy emergency room. So it was simplified, and we have the two-tier, and that is the PE likely, PE unlikely. So if your score is between 0 to 4 points, then we say PE is unlikely. If it is greater than 4, then your patient has a likely chance of having pulmonary embolism. Now, how do we use these predictive tools, clinical predictive tools, in our diagnosis of PE? It helps us to stratify them. Who needs to do a CTPA? Who does not need to do a CTPA urgently? So if you have a score of greater than 4, then it means that PE is likely, high probability, and therefore you don't have to waste time to do any other test than CTPA, which is now the accepted diagnostic test for pulmonary embolism. And so once you can have that clinical prediction, you just go straight to CTPA. Now, where you have the PE unlikely situation, then it means that this patient has a low probability. Low, but it is not 0. So we say that even in this group, the risk of getting the PE is still 7.8%. And so in this category of patients, there is further form of stratification to help us win and sift out those who would not need the CTPA. And so this is where we do the high sensitivity D-dimer testing. And if your patient has a positive value, which is usually greater than 0.5, then there's no further question. You go for CTPA. And then if your patient is negative, which is less than 0.5, there's no further question. PE is ruled out. And when the D-dimer is negative, studies have shown that the probability of having PE is still less than 1%. I know this is a problem. If it is you, you would say that definitely I want to do the PE, even though I could be part of the 1%. So it really depends on who you're dealing with and what your gut feeling will tell you sometimes as a clinician, and what the patient would be satisfied with. Now, apart from the high sensitivity D-dimer, there's also this option where you use the PE rule-out criteria, and that is called the PEC criteria. This is another form of questionnaire. Talks about age, tier questionnaire 8. You talk about age, pulse, what the SpO2 is, whether the patient had hemoptysis, whether there's estrogen use, surgery recently, any prior VTE, and whether there's a unilateral leg swelling or not. So in this case, I would say that then there is no D-dimer available because the D-dimer option is easier. Sometimes others do say that the D-dimer might take a bit of time, and therefore you want to use the PEG criteria. So once a patient scores 1, that means that any of these variables present, it means that the patient's likelihood of having a PE is greater than less than 1%, and therefore you go for CTPA. If it is not, then you have to assure your patient that the risk of having a PE is less than 1%. So this is the PEG criteria. Is it something that is acceptable? Yes, the NICE guidelines will use it. The American Society of Hematologists also encourage its use, but European Society of Cardiology and then the European Society of Respiratory Society do not necessarily recommend this, as there are not much robust studies to show its validity. This is just a simplified algorithm about the PEG criteria. Patient with suspected PE, modified Wells score, less than or equal to 4, assessed with PEG criteria. Absent, no further testing. Present, do further testing. If greater than 4, then you go for the CTPA. We also know that apart from CTPA, there's the role of the VQ scans, okay, which we normally would use for pregnant women or those who may have renal impairment and those who have contrast allergy. Is this available here? Not entirely, but we do have the perfusion scan if we really need to do that at the radio oncology department. But now it is also acceptable to use low-dose CTA protocols for patients who are pregnant. Supportive tests would include echo, BMP, and troponin. Now, I have just limited it to these because these are necessary and it helps with further risk stratifying of patients with pulmonary embolism. Now, once you have made a diagnosis of PE, what is the next level to worry about? Risk stratification. The first one is probability, using the clinical scales. The next is confirming your diagnosis. Diagnosis confirmed, the next level is what is the risk stratification of my patient? Where is my patient as far as this PE is concerned? We talked about the 30-day mortality. Is my patient at high risk of being one of these or not? That is important because it really determines the level of care that you give your patient. Should this patient be inpatient or this patient should be an outpatient for as far as managing PE is concerned? And what is the recommended levels of risk stratification? So the European Respiratory Society and the ESC would recommend that multimodal risk assessment is the best. This is where you use clinical scores plus imaging plus biomarkers. And that is where you are able to give a full assessment of your patient's risk. Now, based on these, there's a clinical assessment, but let me use the combined mode of assessing risk, where you are using both clinical and imaging as well as biomarkers. And this puts our patients in 3 tiers. We have the massive PE patient, who is also said to be the high-risk patient. This is the patient who is hemodynamically unstable. By that, we mean your systolic BPs are less than 90 and below 90 for greater than 15 minutes. If it is less than that, we do not want to call you hemodynamically unstable, or the kind of patient who will need vasopressors, who is in shock. This kind of patient who has a massive PE definitely has a greater risk, greater than 30% of dying from the PE. Aside the clinical stratification using the blood pressure, there's also what we call the assessing for right ventricular dysfunction. How do we do this? We can see this on echo, where we look at the size of the right ventricle, its systolic function. We can also see this on the CTPA, where we look at the right ventricle, its size, looking at the interventricular septum, and looking at its shape to make an inference that this patient probably has right ventricular dysfunction or not. And then also, this is the patient who has both the right ventricular dysfunction and has raised biomarkers, which are either the BNP levels or the troponin levels. So this characterizes this patient as massive, and we've used clinical and use imaging and biomarkers. The next tier is the patient with a submassive PE. This patient has intermediate risk. Risk of dying is 5 to 15%. They are usually normotensive. Their blood pressures are fine. Okay, and then when we look at their imaging, what do we see on the CT or what do we see on the echo? They may have either a right ventricular dysfunction or they have biomarkers. So it is one of each. So they either have evidence of right ventricular strain on echo, or you see the CT, big size right ventricle, straight intraventricular septum, or bent, the D shape, having that appearance or moving to one side, then you're able to tell. Or maybe you did not do an echo, CTPA did not show that, you must get a biomarker, see whether the BNP is raised or not. Now, the thing about this intermediate group is that there's a subclassification into the high risk. The high risk is the one who has the normal blood pressure but has both RV and biomarkers raised. And then the low risk in the intermediate group is the one that has just one of them raised. Then we also have the true low risk. Sorry about that. Then we have the true low risk patient. That one is normotensive. That one has no RV dysfunction, and they have normal biomarkers as well. And so remember the tiers: massive, submassive, two groups: high risk, low risk, and the true low risk as far as stratification is concerned. There's another form of stratification, and that was called the PE Severity Index. So that was used previously before the ERS recommended the multimodal approach. And PSEI still uses some clinical factors: age of the patient, whether there's a presence of a malignancy, etc., etc. Now you score these patients, and then we used to, again, classify them into 5 groups. These are difficult to use in the clinical setting, and therefore there will always be a simplified version. So there was a simplified PESI, where you know whether your patient scores 1 in the next column. So if there's a score of 1 and above, your patient is high risk, simple. If there's 0 score, then your patient is low risk. It's easy to use this one in the clinical setting. So what's the treatment pathway for PE? We all know. Normally, we do the initial low molecular weight heparins or the unfractionated heparins. I'm talking about some few years back. And then we do this for 5 days, looking at the INR, bridging with warfarin, waiting to get a good INR. Then we can drop warfarin, and we can drop the low molecular or the unfractionated and continue with our warfarin. This is where we were. Now we have some simplified and current pathway with the new oral anticoagulants. And so here, Dr. Ejekum has already spoken about the advantages of no INR monitoring, and this new therapies have allowed OPD management of PE. Previously, there's no way that you would manage a patient who has pulmonary embolism in the outpatient setting. With these drugs on the block, we have that ability, but we need to really know the kind of patient that we have to do this for. And for selected patients, there's no need to bridge with low molecular weight heparins. There are fewer drug-drug interactions, and then, as Dr. Ejekum said, very fixed, simple oral treatment available. But how did we get to this conclusion, and how comfortable are we? We definitely have to talk about the Einstein PE trial that was published in the New England Journal of Medicine in 2012. And this, just reminding you, was a randomized open label. It was a non-inferiority trial. What they did was they had a good number of patients, over 4,000 patients, and the whole idea was to look at the role of Rivaroxaban versus the standard care of therapy. That is what I've just described. And the dose they used here was 15 milligrams twice a day for 21 days, and then stepping down to 20 milligrams daily afterwards. Now, what they did was put these patients in the two categories. So you had those that were going to receive Rivaroxaban, and then you have those that were going to do the usual vitamin K antagonists. And here, what I would want to say is that for some of the patients, they still had to do the low molecular weight heparins for 5 days before they switch them over to Rivaroxaban or to warfarin. Others too did not have to do that, and they went straight to get Rivaroxaban. And all this was done based on risk assessments. The endpoint was to look at whether within that period of treatment, was there going to be evidence of or risk of recurrence of their VTE? What about safety, etc., etc.? I want to say here that they did not include the high-risk patients and therefore would affect our conclusions. But when they looked at it after the results, now we realize that preventing recurrent VTE, let me also state here that the duration of therapy was dependent on whether it was provoked or unprovoked. So 3 months, 6 months, or 12 months was what they used in the Einstein PE trial. And the risk of recurrent VTE was 2.1 versus 1.8 in favor for Rivaroxaban. That shows there was no significant difference when they looked at the hazard ratio. And then also with the safety that had to do with the major bleeding, that one, the Rivaroxaban arm, definitely was halved, and that was 1.1 to 2.2. And so based on the Einstein trial, that really made a lot of shifts in the treatment of PE. And this was also made possible with risk stratification, because you realize that that study did not include the high risk. So again, we know who the low risk is. The low risk group, these are those normotensive, no biomarkers, no evidence of changes, right ventricular dysfunction on imaging, echo or CTPA. And so for this group, what do you have to do for them? No need to worry. Their risk of death, 30 days
Sorry about that. I think we're experiencing some technical challenges with Professor Jane Afriya-Mensah's presentation. I think she's experiencing some internet or technical challenges with the device she's using. I'm just going to check. Professor Jane, are you able to hear us? Professor Jane? Okay. I think she's still experiencing some technical challenges. In this case, I would probably request if Dr. Mgisha is available, maybe as we wait for maybe a minute or two for Professor Jane, maybe if you could probably get ready in case we are not able to get Professor Jane back in good time. Maybe you can continue your presentation, and then as soon as you're finished, she can pick up from where she left and finish up with the presentation. So, Dr. William, maybe you can get ready as we will see if we can be able to maybe within the next a minute or 40 seconds to see if we can get Professor Jane back.
Okay.
Okay, I'm just going to make one last call. Professor Jane, if you're with us. Okay, I think we can have a green light also to save on time and just proceed. I will request Dr. William Gisha maybe to pick up from where we are and just maybe finish your part, and then we can go back to Professor Jane when she's back online. Dr. William.
Sure, thank you.
But before you start, quickly, maybe just to give a brief introduction about who Dr. William Gisha is. So Dr. William Gisha is a specialist orthopedic and trauma surgeon at Muhimbili Orthopedic Institute, in brief, MOI, in Dar es Salaam, Tanzania, and an adjunct lecturer at Muhimbili University of Health and Allied Sciences, MUHAS, with a subspecialty focus in pelvis and acetabular surgery, hip preservation, and joint replacement. Dr. Mgisha is recognized for his clinical excellence and academic leadership in musculoskeletal care. He serves as a program manager for the Sign Fracture Care International Initiative at Muhimbili Orthopedic Institute and represents Ortho TV Africa, fostering global collaboration among orthopedic professionals. His research contributions span orthopedic infections, antimicrobial resistance, and esophageal cancer epidemiology, with publication in regional and international journals. A frequent organizer and speaker at surgical symposia and training programs, Dr. Mugisha is a founding member of the Hip and Pelvis Society of Eastern Africa and a life member of the Indian Academy of Orthopedic Surgeons. His accolades include national recognition for outstanding clinical performance and pioneering research, reflecting his commitment to advancing orthopedic surgery and medical education across Africa. Most welcome, Dr. William Gisha.
Thank you very much. Yeah, thank you, Sweetie, for the introduction. So as I've been introduced, my name is William Gisha, an orthopedic and trauma surgeon, but also lecturer at MOI, and I'm in University of Health and Allied Sciences. So in a few minutes, I'll take you through the venous thromboembolism in surgery. As a preamble, MOI is in Dar es Salaam, the capital city of Tanzania, which is about 62 million population as of recent. And I work with Muhimbili Orthopedic Institute, which is the national referral orthopedic hospital for orthopedics, neurosurgery, and trauma, but also it's a university teaching hospital for MUHAS. It's also an AO center of excellence. We have two blocks, the new block and the old block. You can see in the background of the old block on your far right is the Indian Ocean. So we just closed the Indian Ocean. But again, I work with Muhimbili University of Health and Allied Sciences, as I said, in the Department of Orthopedics, Neurosurgery, and Trauma as well. So in a few minutes, I will summarize the epidemiology of venous thromboembolism, of which has been spoken very well by the first and second speaker. But again, I will talk of the risk score pertaining surgical patients and guidelines generally for venous thromboembolism in surgical patients. And then very briefly, I'll touch on the current trend and evidence for thromboprophylaxis in orthopedic surgery. So as has been introduced in the first talks by the previous speakers, venous thromboembolism usually is a bimodal entry point of two pathologies based on the VCOS pathogenesis or the VCOS triad of endothelial injury, hypercoagulable state, and the venous stasis or abnormal blood flow. So the deep vein thrombosis formed usually in the lower limbs can propagate to causing pulmonary embolism and pulmonary infarction in that aspect. So after the formation of a thrombus in the legs, the fate of the thrombus can be four ways. That is, the thrombus can propagate to increase its size, but again, it can dislodge and form an emboli, which will travel into the pulmonary system, causing pulmonary infarction, as I say. But again, it can dissolve eventually, as the previous speaker mentioned. In some autopsies, you may not find the cause of pulmonary embolism, which might have resolved as well. But again, the same thrombus may again recanalize or undergo remodeling, and then you have perfusion and life goes on. So the Vickers triad is the basis for a variety of risk factors which form the hypercoagulable state, but again, endothelial injury, which is contributed by surgical incisions and dissections, but again, trauma and other risks, which increase. So the deep vein thrombosis may change into a pulmonary embolism, and the pulmonary embolism eventually may increase the size of the DVT and forms the vicious cycle of the venous thrombosis. Very briefly, we all appreciate how venous thromboembolism is a serious complication during and after hospitalization. And without VTE prophylaxis, it is very high. The overall rate of venous thromboembolism is very high, and that's why we talk about venous thromboembolism thromboprophylaxis. Otherwise, you would have very high rate of up to 40%, for instance, in medical and general surgical inpatients, 40% rate of venous thromboembolism, and up to 60% rate in the major orthopedic surgery. So we appreciate that with orthopedic surgeries, there are more risks for venous thromboembolism, and that is more morbidity is related to causing pulmonary embolism. But again, fatal pulmonary embolism is uncommon in orthopedic patients if you use venous thromboprophylaxis as such. So the rate of mortality in hospitalized patients for pulmonary embolism is about 10%. And again, about 0.8% in elective surgery patients undergoing bowel surgeries. And the rate may be up to 3% of fatal pulmonary embolism in elective hip replacement, total hip replacement. But again, up to 70% in hip fracture surgery. So we know the case of parotrochanteric fractures, subtrochanteric fractures, but again, femoral neck fractures, especially in the elderly, with other risks of prolonged immobilization and other lifestyle factors, then the risk of pulmonary embolism is very high. You will appreciate that the rate of pulmonary embolism in hip fracture surgery is very high as compared to the hip replacement, but again, other elective surgeries such as abdominal surgeries. And again, death within 1 month is very high, up to 12% pulmonary embolism patients. And the VTE may recur to about 40% recurrence within a 10-year risk of incidence. So why is orthopedic surgery a very high risk for venous thromboembolism? So from the Vickers pathogenesis we talked about, the Vickers triad, endothelial injury, hypercoagulable state, and the venous stasis. The use of tourniquets, but again, immobilization and bed rest as we treat fractures or take care of orthopedic patients, but again, surgical dissections, surgical manipulations, the use of, tourniquets, as I say. But again, trauma itself, if a patient is polytraumatized, then you have to, the patient is at risk of increased thromboplastering agents. But again, you use bone cement for a variety of uses, such as in treatment or the construction of bone defects. So PMMA use is a risk, again, for venous thromboembolism. So overall, orthopedic surgeries are high-risk surgeries for venous thromboembolism, of which if you don't use prophylaxis in indicated patients, then the rate of fatality is very high. And what venous thromboembolism prophylaxis do we use? So they are divided into two broad categories, mechanical and pharmacological. From simple mobilization of a patient who's lying on bed, simple physiotherapy, but again, the use of compression stockings or the use of intermittent pneumatic compression devices and the foot pumps will tend to improve or take away the risk for venous thromboembolism. Apart from mechanical prophylaxis, then you have the pharmacological or chemical prophylaxis, such as the use of aspirin, but again, heparins, the unfractionated heparin, but again, low molecular weight heparin, and vitamin K antagonists, such as warfarin. And as of recent, we have the factor 10, activated factor 10 inhibitors, and the NOACs, the new oral anticoagulants, which are the main focus today, such as Rivaroxaban. So in orthopedic patients and general surgical patients, we use the Caprin score to know what type of venous thromboembolism prophylaxis we should use. So for very low risk patients, they may not need thromboprophylaxis because again, we know the complications associated with these treatments, such as bleeding. And for very low risks, then you may only use mechanical prophylaxis. And for moderate risks, then both mechanical and pharmacological prophylaxis is indicated. And for high risks, then pharmacological and mechanical prophylaxis is indicated. But again, in extreme high risk, you may have extended thromboprophylaxis, which goes to 4 to 5 weeks, as opposed to prophylaxis used only during hospitalization for moderate and low risk. So there are three main columns, of which there are a variety of factors, as surgeons, like age is one of the very key factors to consider, such as the elderly, elder patients, geriatric patients. The score is about a patient who's 75 and above. Then the score is 3. You can see in the middle column in the scoring 3 points. But again, if a patient had a history of DVT, the score is 3 points. And has family history of DVT, the score, the point again is 3. So in all these 3 columns, each will have its own point, and you have to take the total number of points in all the columns and sum them up. So even in a column, if you have multiple factors in a patient, you will need to add them and get a total number of points, and then add on another column if a risk associated, and get a total number of points to get the total score. Of which, at the end of the day, the aim is to score the patient, whether it's a low risk, high, or moderate, or extremely high risk, and know which type of thromboprophylaxis is needed, whether it's mechanical or pharmacological. So some surgical procedures, such as total hip replacement, total knee replacement, elective arthroplasty, these will score 5 points. So, by them, irrespective of the age and other factors, a score of 5 or more is a high risk. So the patient is indicated for mechanical and pharmacological prophylaxis. But again, hip fracture fixation, for instance, especially in the elderly, pelvic reconstructions, all these are high risk surgeries for venous thromboembolism, such that are indicated for thromboprophylaxis, pharmacological and mechanical. But again, if you have a 75-year-old, for instance, who is obese, the score there is 3 + 1, so you have 4. And who is undergoing arthroplasty, that is 9. So any score of 9 and above is extreme high risk. So both mechanical and pharmacological prophylaxis are indicated. And again, these will need to be extended. Instead of giving a short course of 10 to 14 days, which is 2 weeks, for hospital immobilization, during hospital administration, you also have to extend for about 4 to 5 weeks in the extreme high risk. So we have very low risk, moderate, and very high risk, and extreme high risk. So it's just important to remember that for extreme high risks of venous thromboembolism, then we need to have what is regarded as extended thromboprophylaxis, which is both mechanical and pharmacological. So we use the Kaplan score to know what type of thromboprophylaxis is indicated. So let's go through some guidelines in some other countries to know the general idea of what do others do. So the National Institute for Health and Care Excellence, based in England and Wales, for total hip and total knee replacement, for total hip replacement, a low molecular weight heparin is used for high risk patient for up to 10 days, and then aspirin is also indicated after 10 days for extreme high risk patient. So low molecular weight is indicated for elective patient undergoing total hip replacement by NICE guidelines in 2018. And this may be followed by aspirin administration in extreme high risk patients for up to about 5 weeks, that is 35 days. But again, you can see the NICE guidelines also includes Rivaroxaban, but again, apixaban and the bigatran, which may be used for at least 2 weeks after discharge. This is according with the NICE guidelines in England and in the world. But again, patients undergoing total knee replacement, aspirin, low molecular weight heparin, Rivaroxaban, apixaban, and abigatran are also indicated for prophylaxis, especially post-discharge. So the NICE guidelines include the low molecular weight heparin, which is a traditional molecule, but again, the new oral anticoagulants, which have been indicated in high-risk patients. But again, the American College of Clinical Pharmacists, but again, the SIGN guideline, which is not the SIGN, is not the SIGN fracture care, but it is the Scottish Intercollegiate Generation Guideline Network, which is based in Scotland. But again, the British Orthopedic Association also summarized the use of low molecular weight heparin, unfractionated heparin from the Paranox, but again, aspirin, and the use of oral anticoagulants, which may be used for short course, that is up to 14 days, but again, may be used up to 35 days in extreme high risk patients. And we have seen Kaplan score on how we score patients to get the level of severity or the risk. But again, the Canada clinical guideline by 2022 includes the use of the direct oral anticoagulants, such as Rivaroxaban, which is 10 milligram orally once a day in total hip and total knee replacement and hip and knee arthroplasty, which is used for 2 weeks in low risk patients and up to 35 days in extreme high risk patients per Kaplan score. But again, hip fracture surgery, low molecular weight heparin and enoxaparin is indicated per Canada clinical guideline. But again, in a polytraumatized patient who is at high risk of venous thromboembolism, then a low molecular weight heparin is used. But again, spine surgeries, in arthroscopic surgeries, and by this I should say arthroscopy appears to be a minimally invasive surgery in orthopedics. But again, if you factor in other factors to consider, then you find you have to really get the category of your patient. We have had an experience of a patient who was operated right this year who underwent knee arthroscopy. And the worst of it was a medical personnel who passed away. 2 days post-discharge, developed respiratory distress, 2 days after he was discharged, following knee arthroscopy surgery, which is a relatively less invasive procedure, developed respiratory distress and was admitted in a nearby hospital and passed on. So we don't know, we didn't follow up the autopsy results, but venous thromboembolism cannot be excluded. So we really need to categorize and score our patients and categorize patient care, consider all the risk factors to categorize the patient as low risk, high risk, or extreme high risk. And shouldn't just take one factor such as the severity of surgery or the extent of surgery or only the age. So we should consider a number of factors and consider thromboprophylaxis in indicated patient. So from the American Academy of Orthopedic Surgeons, which is the publication 2022 again, international consensus meeting on the venous thromboembolism, we have a variety of conclusions reached in the international consensus meeting in 2022 by the AAOS. So like in venous thromboembolism risk, which surgeries can be considered major and which surgeries can be considered non-major? So basically, total hip replacement, total knee replacement, all arthroplasty surgeries can be considered as major. But again, pelvic reconstructions, hip fracture fixation, those should be considered as major. All those involving the lower limbs above the ankle are considered as major surgeries, whereas foot and ankle surgeries may be considered as low risk or non-major orthopedic trauma surgeries. So upper extremity surgeries and fracture fixations at the level below the ankle may be considered as low risk, while all others should be considered as major orthopedic surgeries and require venous thromboprophylaxis. And what is the optimal venous thromboembolism prophylaxis for patients undergoing internal fixation of the hip fracture? So the American Academy of Orthopedic Surgeons gave a guideline in 2022 that mechanical and pharmacological venous thromboembolism prophylaxis are indicated in hip fracture fixation, especially in the elderly. And low molecular weight heparin is indicated for up to 28 days in high-risk patients. But again, the American Academy of Orthopedic Surgeons considers the direct oral anticoagulant drugs such as Rivaroxaban, such as the case of activated factor 10 inhibitors. But again, aspirin, low molecular weight heparin, and other anticoagulants. But again, we need to stratify the risks in our patients. And what is the optimal management in patients with antiplatelet or anticoagulant presenting with acute extremity injury? What will clinicians do? What will orthopedic surgeons do? In a patient who was on low molecular weight heparin and requires to undergo another surgery or has sustained other injuries which necessitate surgical management, then low molecular weight will need to be stopped for at least 12 hours prior to surgery. But again, the American Society for Regional Anesthesia recommends cutting off rivaroxaban for at least 22 hours prior to surgery and initiation of axial block. So we may need to stop these medications 12 hours prior to surgery in low molecular weight heparin, but again, up to 22 hours if a patient was on Rivaroxaban. So we have the novel oral anticoagulants or the direct oral anticoagulants, apart from the traditional low molecular weight heparin, which requires monitoring. We know low molecular weight heparin requires monitoring of at least 6 hours of the PT-PDT and the INR. So you will find that low molecular weight heparin is suitable for admitted patients, for inpatients. That again requires frequent monitoring, especially in ICU patients. And it has complications associated with, again, bleeding if the therapeutic window is not titrated enough. But the direct oral anticoagulants may not require such tight regulation, such tight monitoring. Warfarin, for instance, should also be monitored at least once a day, 24 hourly in the first week. But again, after that, subsequently, every week you need to get the PT, DT, INR, and other coagulation profiles. So the direct oral anticoagulants, such as the factor 10, activated factor 10 inhibitor, such as Rivaroxaban and others, factor 2 inhibitors, do not need such tight regulation or monitoring and are convenient for outpatient basis, as mentioned in the previous talks. So apart from warfarin and low molecular weight heparin, we have the direct oral anticoagulant therapy, which are new molecules, and they offer a new window or a new hope for treatment or for prophylaxis of venous thromboembolism. So they have narrow therapeutic windows as opposed to low molecular weight heparin and warfarins, but again, they do not need regular monitoring. So Rivaroxaban is a DOAC. It's a direct oral anticoagulant. It's the first commercially available oral factor 10A inhibitor. The half-life is about 9 hours, 5 to 9 hours, but again requires clearance or is cleared metabolically by the kidneys. And so it needs to be tightly regulated again in the patients with renal insufficiency or acute kidney injury, chronic kidney disease. So in patients with chronic kidney disease, you may need to use other anticoagulants than Rivaroxaban. But again, it has been approved in by US FDA in orthopedic surgery, prevention of stroke, but again in treatment and prophylaxis of DVT, PE, but again in preventing recurrence of PE. So in VTE prophylaxis, Rivaroxaban can be given at 10 milligram once a day for at least 12 days for a short course in the low-risk patients, up to 14 days. But again, it can be extended to up to 25 to 35 days in extreme high-risk patients. But again, apart from Rivaroxaban, another direct oral anticoagulant therapy available is Apixaban, which is also a direct factor 10A inhibitor, which is used for a variety of indications, including prophylaxis and treatment of venous thromboembolism, including pulmonary embolism. So Apixaban can be given 2.5 milligrams twice daily, which is started usually 24 hours post-surgery, and can be given up to 2 weeks in low-risk patients and up to 38 days in extreme high-risk patients after total hip replacement, for instance. So how effective are these drugs apart from Rivaroxaban, Apixaban, and other edoxaban? So there is systematic review and meta-analysis, which included 61 studies evaluating about 11 anticoagulants in total hip replacement and total knee replacement, which was published in the very famous Journal of Medicine, the Baltimore Journal of Medicine. And it found out that from this systematic review and meta-analysis, Apixaban, edoxaban, fonporonax, and the Rivaroxaban, along with the Rivaroxaban, are the most efficacious agents in prevention of venous thromboembolism in total hip and total knee replacement. But again, we have these trials, the regulation of coagulation of orthopedic surgery to prevent deep venous thrombosis in pulmonary embolism, the record trials, which were conducted about 15 years ago, which were of different phases and different levels, but again included about 12,500 patients in about 39 countries. That is, there were multi-center, multinational studies, RCT, I call it RCTs, of which we have the record 1, record 2, record 3, and record 4. The record 1 was for thromboprophylaxis in total hip replacement, in extended thromboprophylaxis, using of which patients were categorized into Rivaroxaban, but again randomized into Rivaroxaban group and again into enoxaparin group, of which in the record 1 trial, all patients had extended thromboprophylaxis for about 39 days, and of which Rivaroxaban was non-inferior to enoxaparin in terms of venous thromboembolism formation in the rate of venous thromboembolism, PE and DVT. But again, in the record 2 trial, which were used for 39 days in the Rivaroxaban group, and only for 2 weeks in the enoxaparin group, just to find the efficacy of the rivaroxaban in the extended thromboprophylaxis line, and it was found to be highly efficacious. But again, the record 3 and 4, which were a total knee replacement, overall, rivaroxaban was found to be non-inferior as compared to the traditional enoxaparin, which is a low molecular weight heparin. So one of the details of the record trial, which was published in this high impact factor journal, the New England Journal of Medicine, rivaroxaban versus enoxaparin in the thromboprophylaxis after total hip replacement, to compare the efficacy of the two drugs in extended thromboprophylaxis in patients who underwent total hip replacement. As I said, there were about 591 patients were categorized into a rivaroxaban arm and an enoxaparin arm, of which at the end of the day, about 1,500 patients, 37 patients, were in the rivaroxaban group, and 1,492 were included in the enoxaparin group. And the primary efficacy outcome was to compare the rate of venous thromboembolism in the two arms, and of course, compare the rate of complications such as bleeding. So overall, there was very high rate of the composite in the enoxaparin group of the complications, including the venous thromboembolism. So enoxaparin group, the low molecular weight heparin, formed about in 4% of patients. So you can see the rate was about 4 times the rivaroxaban. So rivaroxaban was found to be highly efficacious in prevention of thrombosis post-total hip replacement in the two groups. So, but again, rivaroxaban had a very low rate of complications as opposed to enoxaparin, as the case of 0.2% versus 2% in the low molecular weight heparin. So overall, rivaroxaban was found to be non-inferior, as I say, to low molecular weight heparin in terms of complications. So a 10 milligram dose of rivaroxaban was significantly more effective for extended thromboprophylaxis, that is, for administration of thromboprophylaxis for about 4 to 5 weeks, once a day, as opposed to a 40 milligram routine or traditional low molecular weight heparin and enoxaparin in patients who undergo total hip replacement. The two drugs had same or similar safety profiles in terms of bleeding. So instead of using injectables, even in outpatients, you would consider rivaroxaban, which is the direct oral anticoagulant, as opposed to the injectables of low molecular weight heparin, which also required tight ligation. So overall, I should say that as Prof. Jane mentioned in her talk, which was cut short, unprovoked venous thromboembolism, it means the risk factors were not identified. So for unprovoked venous thromboembolism, these patients will need to be on anticoagulation for at least 3 months, according to the American College of Chest Physicians. But again, once they have a recurrence of a VTE, these patients will need to be on anticoagulation for life. And they need to attend hematologist clinic, which is, they have like right here at the Mwimbili complex, we have what you call the anticoagulant clinic, and patients need to show up for the rest of their life in hematologists for follow-up. But for provoked venous thromboembolism, such as those following surgery, following hip fracture fixation, following total hip replacement, pelvic reconstruction, these require up to 3 months, especially prophylaxis in extreme high risk patients, and if they had extended exposure of risk factors, especially immobilization. But in patients who have provoked venous thromboembolism, the risk of recurrence is very minimal, as opposed to those who have unprovoked, what we call medical-related venous thromboembolism. So this indicated, as Prof. Jane mentioned, again, to score the risk of recurrence, the possibility of recurrence of a venous thromboembolism. And such patients with continually elevated levels of D-dimer will need to be on rivaroxaban or other anticoagulants for the rest of their lives until D-dimer levels go beyond, become normal. But again, D-dimer levels and duplex ultrasonography or venographies are the two tools used in diagnosis of the risk, again, of venous thromboembolism, and such that presence of a thrombus on ultrasonography, duplex ultrasonography, but again, elevated risk D-dimer levels, such patients are indicated on prolonged anticoagulation therapy. So major orthopedic surgeries for venous thromboembolism include total hip, total knee replacement, or arthroplasty in general, but again, pelvic reconstruction, spine, and pole traumatized patients. Such patients will need to be considered to have both mechanical and pharmacological thromboprophylaxis, irrespective of other risks, including obesity, like the age, and other risks. But non-major surgeries such as arthroscopy, upper extremity surgeries, and foot and ankle surgeries, these are considered as low-risk surgeries for venous thromboembolism. Although patients need to be individualized, as I gave an experience of a patient who underwent a knee arthroscopy, but again succumbed only day 2 post-discharge. So we cannot exclude venous thromboembolism as the cause of death in that patient specifically. But again, we've had patients, of course, despite venous thromboembolism prophylaxis in the wards, who succumbed day 1, day 2 post-surgery, right in the ward, post-hip replacement. We have had such cases. So as orthopedic surgeons, we need to have Caprin score in hand, especially when handling major orthopedic surgeries. Individualize patients, score them, and start them on mechanical and pharmacological prophylaxis to reduce the risk of venous thromboembolism. But again, direct oral anticoagulants, these are effective anticoagulants that I've seen through the RCTs, the meta-analysis, and the Rivaroxaban is a premium molecule that need to be considered in thromboprophylaxis, but again, in treatment of venous thromboembolism. Thank you very much.
Thank you very much, Dr. Mgisha. Well done, and I think a well-executed presentation. I would say, as you have mentioned, surgery puts many patients, particularly major orthopedic surgeries, puts many patients at risk of venous thromboembolism. And I think you've taken us through with much more insights from how probably a patient, such patients can be managed and actually put on medications which, other than the traditional ones, can really benefit from the new DOSs, and of particularly Rivaroxaban in their management to help them be more adherent and, of course, reduce the invasive, I would say, administration, which is involved when you inject a patient with an injectable. So I think well done and a very well executed presentation. At this point in time, we have Professor Jane back. Professor Jane is back, and I would like to give her an opportunity to complete her presentation. Sorry, Professor Jane, for the technical challenge you experienced, but I think we still are eager and ready to listen to the remainder part of your presentation. So please, back to you, Professor Jane.
Okay, so sorry about that glitch. I hope you can hear me.
Yes, loud and clear.
Okay, so thank you very much. Let me quickly go back to where we were. So I think I was talking about the Einstein PE trial that did show that Rivaroxaban was good enough to use for outpatient management of PE. And this is just with the low risk group. Anybody with an intermediate risk group, whether the low risk in it or the high risk in it, needed to be in hospital. And therefore, the recommendations by the European Respiratory Society was that there will be a bridging with low molecular weight for 5 days, then you switch over to Rivaroxaban. And then also, I made mention of the high risk category. For these people, they are those who are hemodynamically unstable and definitely would need thrombolysis or unfractionated heparin perfusion or catheter ablated therapies before we switch them on to Rivaroxaban. So this is just for knowledge. If you look at the high risk group, there's also the caveat that where we don't have thrombolysis, can we still do the unfractionated heparin bolus? Yes, it will save the time for the moment, but I think from this study by Sergio et al., thrombolysis is still the best because it neutralizes and dissolves the clot and therefore rapidly restores pulmonary perfusion. Whilst if you do the unfractionated infusion, it does not give you that benefit. You need time for the body itself to lyse the clot, and therefore it would always be advantageous to have thrombolysis over our old method of unfractionated heparin. So I want to also let our listeners know about the transition protocol. So for the intermediate or the high risk group, let's stay with the intermediate group. If assuming you have a patient with PE that you have started on low molecular weight heparin, how do you bridge to Rivaroxaban? Because here we don't have any monitoring with INR. So what is said is that Dr. Jeku mentioned how rapid onset Rivaroxaban is, so you don't need to bridge like we used to do with warfarin. So all you do is you give your low molecular weight heparin for 5 days, 1 to 5 days. Whenever you want to switch, the day you want to switch, you omit the low molecular heparin dose, and then about an hour or two later, you can start or give your oral Rivaroxaban. So this is for those who would always want to question. Sometimes, if you look at the Einstein PE trial, the switch was done on day 5, after day 5. But really, sometimes we have these low risk patients coming into our emergencies. You know that they don't have any risk of mortality 30 days. And so you want to manage them on outpatient. But probably you would have started low molecular weight already. I think there's also room for earlier switch, just that you know that on the day you are switching, you don't administer the low molecular weight heparin. So Rivaroxaban role, we've talked about its role in acute PE management or subacute PE management. We've said that these people are liable to have, or they are the patients who can have outpatient management straight onto Rivaroxaban, low risk, intermediate, and the rest not for that. You need to bridge with low molecular weight. Now, does Rivaroxaban play a role in secondary VTE prevention? That is, you have already completed your 3, 6 months, or 12 months of anticoagulation therapy for a PE. Do you still feel that the patient has some risk of getting a recurrent VTE? Or is there a clinical equipoise where one doctor says, I think the risk is gone, the other person says, no, I think this person still. So there is some level of uncertainty. These are the kind of patients that we ask the question, can we put them on Rivaroxaban for a protracted period of time as a means of having extended secondary prevention? Yes, the Einstein choice trial gave us this opportunity where they looked at PE patients who had completed 6 to 12 months of anticoagulation but still had an existing moderate risk, or where it was an unprovoked case. So you really don't know what happened. And then also the situation where there's always a clinical dilemma. They excluded high-risk patients who necessarily have a high risk of VTE. Now they looked at giving Rivaroxaban 20 milligrams, 10 milligrams versus using soluble aspirin 100 milligrams. And these patients were randomized into a 1:1:1 ratio. And what they did was that they continued these doses one additional year after their original treatment for PE. So if they had 6 months, we added 12 more months, and that was 18 months. And within that period, the Einstein choice trial was looking at risk of recurrent VTEs. And to say, when they looked at the results, there was no significant difference between the dose of Rivaroxaban 10 milligrams and 20 milligrams. But definitely, if you look at the figures, 1.5 risk of recurrence for 20 milligrams Rivaroxaban, 1.2 for 10 milligrams, and 4.4 for soluble aspirin. I think this debate has already been settled. Soluble aspirin does not protect anybody against VTE. And so here, the question was, is 10 milligrams better? Is 20 milligrams better? There was no significant difference between the 1.5 and the 1.2, looking at the hazards ratio, and therefore the lower the dose, the better. So Rivaroxaban was superior. Bleeding risk was actually insignificantly different amongst all three. So if 10 milligrams can work for me, then that was where the practice came from, that we can use 10 milligrams Rivaroxaban for extended secondary VTE prevention for patients who have completed their treatment for acute PE with doubts on their risk. Now, there's also the talk about, we've talked about acute and subacute PE. How about the chronic PE patients who go on to develop pulmonary hypertension? So this is still being debated, and WHO says that it depends. The European Respiratory Society says that it depends on actually the class of pulmonary hypertension that we are talking about, and not every case of pulmonary hypertension who needs to be put on anticoagulation. So class 1, we know class 1 is the pulmonary arterial hypertension group. Now ESC-ERS says that this group, despite the pathophysiology, do not need routine treatment with anticoagulation for prevention of VTE. You always have to look at the risk versus the benefit analysis. Studies have gone to prove this, and therefore they looked at data from very old studies. The oldest one is the Compara registry that suggested that if you put these patients in class 1 pulmonary hypertension on anticoagulation, they benefit, and there was a survival benefit, reduced risk of VTEs. Reveal registry looked at it again and said, no, there was no advantage. And rather, in a certain group of patients who had connective tissue disease scleroderma, they had more bleeding, major bleeding episodes that led to increased mortality. So this did not help us. A meta-analysis was done by Wang et al. In 2020, and again, the results were conflicting. So this has been left to clinicians for patients who have class 1 pulmonary hypertension. A risk versus benefit analysis needs to be done per the guidelines. Now, for those who have class 4 pulmonary hypertension, and that's the CTEP group, that's those who have the chronic thromboembolic pulmonary hypertension. For them, it is strongly recommended that these patients are put on anticoagulant therapy. And the preferred one has always been warfarin based on previous studies. But what is on the ground or in the real world situation is that most clinicians are using the direct oral anticoagulants because of their convenience and the way it works for patients. And patients will normally choose this if you involve them in this decision making. So this is what guidelines says: warfarin, keeping the targets between 2 to 3, but we need data to support this. And so there was some study that was done by Bharati et al. They looked at 96 patients who had undergone pulmonary endarterectomy, meaning the source of their CTEF has been dealt with, but we know that these patients will still require anticoagulation. They randomized them into a warfarin arm and then into a Rivaroxaban arm. The endpoints were we going to get rethrombosis of the pulmonary artery? Are these patients going to come on admission frequently? Bleeding and mortality at these specific months after surgery. And the results was no significant differences between these two patients. And so the conclusion was that, well, if I can have and achieve this with Rivaroxaban vis-a-vis warfarin, then why can't we put our patients on the DOACs? And then there was another study by Sina et al. That looked at patients who had CTEF, that is a chronic form of pulmonary embolism. They looked at 501 cases in their clinical review. So it was a retrospective study. And also they had these endpoints of VTE recurrence and safety. And again, there was no significant differences in the VTE recurrence, but major bleeding was noted in the warfarin arm. The conclusion here is that then using the DOACs is more reasonable because I can still achieve minimal recurrence of VTE at a less risk of bleeding. And so even though these few studies have come up, the ERS Society would want prospective randomized controlled trials to be able to make a bold statement on this. But using these studies in a nutshell, would say that most clinicians are happy to use Rivaroxaban at a minimal dose of 10 milligrams for extended or prophylaxis in patients who have pulmonary hypertension. So looking at these few studies that I've presented to you, both in acute PE, in chronic PE, Rivaroxaban plus the others, which includes apixaban, those two are what are licensed for outpatient management of pulmonary embolism. Dabigatran is not, because its bioavailability is unreliable, and therefore you cannot necessarily be super happy with it for managing an acute PE on outpatient basis. So where dabigatran is being used, low molecular weight heparin bridging is always required. But in effect of the the drug, the molecule that we are talking about now, we are happy with its rapid onset of action, superior bioavailability, rapid onset of action, effective for daily dosing, and then it has really made low-risk PE management simple and can be done on outpatient basis. And we're happy to have it for extended secondary prevention and also for patients with class 4 pulmonary hypertension. Thank you very much for your attention, and then I'll wait for questions and answers.
Thank you very much, Professor Jane. Well executed. Despite the technical challenge, I think it's finished quite well. We are almost going to the Q&A section, but just before the Q&A section, I will quickly like to just present a few points about the company which is sponsoring today's meeting, Fosun Pharma. I'll quickly take you through some little bit of information about Fosun Pharma as a company. Yeah, perfect. Thanks a lot. Oops, sorry. Second. So Fosun Pharma as a company, as I continue to upload my slides, Fosun Pharma as a company is a Chinese-based company, the third largest company, I would say, in China, but of course with a global footprint. I mean, globally present in most countries and continents as well. I'm just trying to make sure I'm able to get my slides. Oops, it's not the case. Okay, so I'll just give a brief. I'm trying to upload it, but it's not able to show. So Fosun Pharma as a company is the third largest pharma company in China, and with a global footprint, present in over 28 African countries, and part of our offices are in France, and this is the relationship between Fosun Pharma and Trident Pharma. So Fosun Pharma owns Trident Pharma, which is uniquely based in France, while the head office remains in China. And we are proud to say we have over 8 manufacturing sites across the world, with the most recently being built in Ivory Coast. I think that's a point to highlight, that we even have a manufacturing flight being developed in Ivory Coast as a starting point, and for sure they will continue being developed across the African continent to make sure the medications are easily accessible and more available and affordable, most importantly, especially in resource limited settings like ours. So that's an important point to highlight. Coming back to the meeting today, I think it's been excellently organized, together with my 2 colleagues, David Blay Tanoe from Ghana, who's a country head of Ghana, as well as Sant Tripathi from Tanzania, who's a country head or country manager for Tanzania, responsible for our Tanzanian operations. Really many thanks to Sant and David. And also, as a last point, or as the most important point, is that today, in this very moment, I think it's an opportunity to highlight that we are introducing our brand of Rivaroxaban in Tanzania and Ghana for the first time across the English-speaking African countries by the brand name Varosun. So that's the brand name we are currently having in our portfolio. Varosun is the brand, and I'm just presenting. Is it possible to share my screen? Yeah, perfect. So Varosune is a brand of Rivaroxaban from Fosun Pharma, currently launched in Ghana, Tanzania, Mali, Ivory Coast, and Cameroon, Gabon, and Benin as well. As you can see, that's a packaging on the left, on the right-hand part of the screen. And I think importantly to highlight is that Varosune is, I would say, equivalent or bioequivalent to the originator Rivaroxaban, and this basically means it ensures high efficacy, high quality, and high safety to the patient. So from a confidence perspective, as a HCP, when you're prescribing Varosune, you can be confident in the back of your mind that you're issuing or you're prescribing a treatment which will produce high efficacy, impart quality to the patient's well-being, and of course, importantly, at a very high safety profile to the patient. These are the two I would say packaging that you have, 10 milligrams and 20 milligrams. Soon as well, we'll be having the 15 milligrams available in the market. And I think from there, it's going to be quite easy for each and everyone in this particular meeting to be able to extend the benefits of Varosune to the patient. So all these strengths at this point in time are available in Ghana and in Tanzania whenever possible, whenever you get an opportunity to use an anticoagulant, and particularly a Rivaroxaban, choose Varosune moving forward. So that's it for my presentation. Thank you very much. And I think I invite the next session, which is a Q&A session, where we will start off with the first question. I believe it's going to be from Dr. Martin Adayele Atuguba. He's asking, do you need to do a clotting profile before starting Rivaroxaban? Do you need to do a clotting profile before starting Rivaroxaban? I probably will refer this first question to Dr. Ajikum. If you're on, please just switch on your mic.
Hello, can you hear me?
Yes, loud and clear.
Okay. Yes, so technically you don't need, but as part of the full evaluation of your patient, let's remember that it doesn't affect your INR much, but you need to be aware of the patient's bleeding risk. So as part of your general evaluation of the patient, it is always important to get your INR, because we say that has blessed score, you have what we call labile INR that helps you to evaluate the patient's bleeding risk. So of course, if the INR is high, you are not going to further put the patient on any of the drugs. So as part of our routine practice, we do assess the INR before we put them on.
Perfect. And there's another question, I think, particularly directed to you in this case. If Rivaroxaban is non-inferior to warfarin, why not use in atrial fibrillation management for patients with severe mitral stenosis? I'll repeat the question. If Rivaroxaban is non-inferior to warfarin, why not use in atrial fibrillation management for patients with severe mitral stenosis? That's from Dr. Ilomo.
Okay. Thank you very much. I mean, that's a very important question. Now we deal with what we call evidence-based medicine. So the evidence we have is that when it comes to moderate to severe mitral stenosis, I've forgotten the name of the study. I think it was Invictus study that was done. Rivaroxaban was inferior to warfarin in that specific circumstance. So it is not prescribed in those specific circumstances. Moderate to severe mitral stenosis, and also in patients with prosthetic valve. Otherwise, all other circumstances, we have the strong evidence that is non-inferior to warfarin. And that is why we do that. So it's based on the evidence we have as at now. Thank you.
Okay, perfect. Thanks for that response. I believe we're still on atrial fibrillation, and there's another question to you as well. Why not giving DOAC to patients with atrial fibrillation with moderate MS and rheumatic mitral valves? Why not giving DOSC to patients with atrial fibrillation with moderate MS and
I think the
rheumatic
same answer
mitral
applies,
valves?
that we don't have evidence for its use in that specific circumstance, and we are dealing with evidence-based medicine.
Okay, perfect. Perfect, great. And probably one last question, particularly from your end, maybe probably the other questions, but this one still applies to atrial fibrillation. When do you combine anticoagulant and antiplatelet therapy in atrial fibrillation? From Dr. Elias Ewudzi.
Okay, thank you very much. I think I mentioned it during the presentation. My recommendation should be for specialist use, and especially for patients who have ischemic heart disease, acute coronary syndrome, and then they also have atrial fibrillation. In that case, you combine the DWAC with the antiplatelet therapy for some time before you stop the antiplatelet and just continue with the anticoagulant therapy. But let's know that every combination comes with a higher bleeding risk, and this must be managed under specialist care. Thank you.
Okay, perfect. Thank you very much, Dr. Ajekum. I believe the next question is going to Professor Jane. Which assessment tools have been validated in risk stratification of VTE, particularly DVT and pulmonary embolism risk, that direct prophylaxis as opposed to Wells score, which is for diagnosis? In brackets, tools are there studies that have evaluated the roles of DOSCs in VTE prophylaxis for high-risk patients admitted in hospitals?
Hello, I wish you could put the question on the screen so that it's easier, but maybe if I can paraphrase, the patient is asking why we don't use the DOACs for high-risk patient. And then number two is asking for the criteria for assessing risk.
Correct.
Okay, so the criteria for Wells diagnosis is criteria is not for assessing risk. It is just for determining who is likely to have PE. But when you have risk assessment, the validated tool was the PE severity index, which is the PESI criteria that I showed. PESI. So you can Google that up. It has a number of simplified questions using only clinical data. But currently, the guidelines recommend using multiple tools. So you use both the clinical, then you use the RV dysfunction and the presence of biomarkers like troponins. So that is what is encouraged. Multimodal means of assessing risk is encouraged. And you always will get these when you Google them up, so you don't have to put them in memory, and it's easy to apply and risk stratify your patient. The other one had to do with why we don't use it for high risk patients. As per all studies, it is unethical to include patients who are high risk of having an adverse event in clinical trials. And so, as the data is now, it does not support us using these in high risk patients. However, in the setting of pulmonary embolism, when you have managed the acute phase, and the patient is stable, assuming the patient was high risk, you've given your thrombolytic therapy or you decided just to do low molecular weight. Once the patient is stable, you can switch them on to the DOACs. So it is unlike the others you need to maintain on warfarin. In this case, you can switch them over to DOACs when they are stable. Thank you. I hope it answers the question.
Yes, I think it does. Thank you very much. I think the next question still remains for you, Professor Jean. What level of care in the management of pulmonary embolism should be referred to a tertiary facility. Can low and intermediate risk be managed by general medical officers at the district level? The question is on the screen as well.
Yes, thank you. So I would say that low risk patients can be managed by medical officers at the district hospital. When it comes to intermediate risk, I remember I said that there are two categories there too. You have the intermediate low risk and then the intermediate high risk. The thing about the intermediate high risk is that they can easily deteriorate into the high risk group. So for safety, it is said that for those in the intermediate group, if all things are possible, refer them to the next level of care before they deteriorate. You can start your initial therapy definitely whilst you refer them. Because for all levels of pulmonary embolism, the mantra goes that once you think PE, start treatment until you can confirm or disprove your pulmonary. So that's my advice. Thank you.
Okay, perfect. I believe, thank you very much, Professor Jane. The next question would go to Dr. Mugisha. May you briefly touch on the incidence of VTE in black versus white race undergoing major orthopedic surgery?
Yeah, thank you very much, Dr. Mboya. It's true that literatures have indicated that the risk for venous thromboembolism is higher among the Caucasians, among the whites. But again, as of recent, we have seen the increasing data reporting on the same incidents or similar incidents of venous thromboembolism, PEDVT, among blacks. So it might be that we're missing to diagnose it. But overall, there are other risks such as the hypercoagulable state, such as the factor V laden, which is a genetic risk, which is higher in the Caucasians. I'm yet to see studies which have compared the major orthopedic surgeries among the whites and blacks, but we have had a lot of evidence out there that the risks for venous thromboembolism are higher among the Caucasians as opposed to blacks. But again, there is some skepticism that we may be under-diagnosing them, and especially because among the sub-Saharan African countries, we rarely do autopsies. And our friends, the whites, do autopsies in most of cases. And they have maybe some highly advanced diagnostic tools to pick up the venous thromboembolism.
Thank you very much, Dr. Mugisha. There's another question from Luginio Ilomo. If I use half a tablet of 20 milligrams Rivaroxaban, will it give the same effect as 10 milligram formulation? I will direct this question probably to you, Dr. Mugisha, and of course, Professor Jane and Dr. Gekum. Any comments on the same?
Thank you very much. Maybe I will start. I don't know why was that question posed. Looks to be a good question, but that's mathematics, not even orthopedics or medicine. It's half of 20, which is 10, and again, equivalent to the 10 milligram. I think that's mathematics, not even orthopedics. I think it will give the same effect, except on maybe whether it's talking of the pharmacodynamics or what you call the bioavailability on how you divide the tab into exactly half. That is something else which may be to be answered or responded by maybe physicians or some pharmacists. Yeah, thank you.
So this is an interesting question. Yes, I would say that most of the tablets formulations we have are not scored, like Dr. Nisa said. They are not scored. So you are likely not going to be able to divide it equally. And besides, anybody who needs 10 milligrams is definitely somebody you have just thought has a moderate risk of getting again. So you are just giving prophylactic. And so in that case, we will not advise you to divide. Sometimes what we do is you could take it on alternate days. Although we know that the bioavailability would be for 24 hours, it will not even be up to that. It's up to some 16 hours in a day. So it's advisable not to break the tablet, but get the dose that is required. Thank you.
Okay. Thank you very much,
I
Professor
completely
Jane
agree
and
with the
Dr.
answer, so
Mugisha.
there's no need for any more.
Perfect. Yes, I was going to ask if you have any comments, but I think with your agreement, I think we have fully exhausted this particular question, Dr. Ajikum. I believe the next question from Kubi is coming straight to you, Dr. Ajikum, as well. Can atrial fibrillation be managed at the district level, or all should be referred?
That's a very tricky question. I think if you have doctors at the district level who can fully assess the patient with atrial fibrillation, you have those things available. We mentioned the risk factors, we mentioned the left ventricular function assessment and all those things. If you can have them done there, together with thyroid function tests, liver function, and everything, then there is no need to refer if the person does not have any, difficulties. Straightforward atrial fibrillation. However, if it is a patient with several comorbidities, which tends to happen in atrial fibrillation, you would need a specialist care, and therefore may need a regional level or a higher level care for the patient with atrial fibrillation. Thank you.
Dr. Whitty, you're muted.
Sorry about that. Sorry. So the question is, how long should a patient be on Rivaroxaban? I think this is a question which can be open to all the speakers. How long should a patient be on Rivaroxaban? Maybe Dr. Mugisha, you can go ahead with your comments.
Yeah, thank you very much. As we mentioned, it was previously mentioned in the first talk by Prof. Jane that we may need to consider venous thromboembolism in two main categories, the provoked and unprovoked. With the provoked venous thromboembolism means you know the risk associated with developing venous thromboembolism, such as DVT, PE developing following total hip replacement or total knee replacement. That is, the risk is surgery, the surgery itself. So such a patient will need to be on extended thromboprophylaxis if he's an extreme high risk patient by what you call the Caprin score, as I mentioned. That is up to 5 weeks. But once he develops another VTE, that is a DVT or a PE in another subsequent setting, then he will need to have the Rivaroxaban for at least 3 months. But once you have a medically related pulmonary embolism or DVT that is unprovoked, and we do not know the exact cause, then the patient may need to be treated for 3 months. But again, once he develops these similar incidents, the patients, or what you call recurrent VTE, the patient may need to be on Rivaroxaban for the rest of their lives. And that is those are better handled by physicians or hematologists on anticoagulants clinics. And I think Prof. Jane and Dr. Jakum will be in the better position to respond on the same. But with the surgical patients, the first incidence, we want to prevent venous thromboembolism. And once the patient develops the venous thromboembolism, then we treat it. And once it has recurred, we have to carry on for at least 3 months. Once it recurs the other time, then the patient needs to be on anticoagulant almost for the rest of their lives. So it is important to consider the risk in such two broad categories. Thank you.
Thank you, Dr. Mugisha William. Professor Jane?
Well, I think Dr. Mugisha has hit it right there. The duration really varies and depends on a number of factors. Thank you.
Okay, perfect. Thank you very much for exhaustively answering that particular question. Another question, thanks for the presentation. Please, with regards to we the clinicians at the periphery who does not have the luxury of doing the sensitive D-dimer test, the biomarkers and the imaging techniques, what should we do when we suspect a patient of pulmonary embolism? what's the risk of starting treatment versus not starting? And secondly, what are the referral agencies when you suspect a patient of having pulmonary embolism? Thank you. This is Luvi Eli Yao. I believe this question is again back to you, Professor Jane.
Okay, so that is why I gave the PEC rule, which is the PE rule out criteria. So that criteria was simply using clinical factors. What I would say is that if you do not, in fact, like I said, if the mantra is that once you suspect PE, you treat. You don't wait to get any form of confirmation. You have to start treatment immediately. So with the PEC criteria, assuming you don't have the dimers, as you have rightly said, how do I rule out to say whether this patient should go for a CTPA or not? The PEC criteria, again, is online. It says age less than 50. If it is true, it scores 1. Pulse, if the patient is aged more than 50, you score 1 for that. If the patient has a pulse greater than 100, it's 1. Is the SpO2 less than or equal to 95? Does the patient have hemoptysis? Is the patient on estrogen? Has there been surgery within the past 4 weeks? Has the patient had VTE before? Or is there unilateral leg swelling? If you have these, any of these being present, even one, it means that start treatment and go and do CTP. So with PE, there's no room for wait for your confirmation before you start treatment. Once you think it, treat. Then you look for ways of confirming. If you confirm and it's negative, you stop treatment. If it is positive, you continue. So there's nobody should say that I'm waiting to get some risk of not starting treatment or starting treatment. We don't have that luxury. PE comes into your mind as a doctor, give treatment and make steps to confirm or disprove. Thank you. You are muted.
Thank you very much, Professor Jane, once again for exhaustively responding to that question. Another question from Dr. Andrew Nana. For how long should we monitor the INR of a patient on DOAC? Probably I'll throw this question to Dr. Ajikum. For how long should we monitor the INR of a patient on DOAC? Dr. Ajikum?
Okay, maybe he's not. So I would say that INR monitoring is not recommended in the use of DOACs because they do not affect INR. And so once when you are initiating, you just want to know what the INR is, like Dr. Ejekun said. But after that, you don't monitor INR for a patient on a DOAC. That is why, in fact, most studies have excluded the high-risk patient, because with a high-risk patient, you want to be sure that I am between a target of 2 to 3. But with the DOACs, really, there's nothing to monitor. Studies have shown that there's good bioavailability, but how do I know I'm in target? That is why there hasn't been comfort with a high-risk patient. So please, no INR monitoring. Thank you for DOAC.
Thank you very much. I think we'll be taking maybe 2, I would say, last questions before we come to a close. I think time is not very much on our side. Probably one, and then the next question, and then I think we can come to a close at this particular point in time. Maybe the question from Kubi: in left ventricular thrombus, which is superior, warfarin or rivaroxaban? In left ventricular thrombus, which is superior, warfarin or rivaroxaban? Would have gone to Professor Jane.
So this one,
Dr.
when it is in the heart, It is for Dr. Jekum.
Yes, I thought so, but
Unless,
looks like he's not
he's not
around.
available. Yes.
Yeah.
So again, if you have a patient with a visible thrombus in the left ventricle, it presupposes that this thrombus is forming on the background of myocardial disease. So once there's a background of myocardial disease that needs attention, it means that the patient's risk of forming more clots, it's quite high. This patient also has a very high risk of embolizing this thrombus into the brain. And so for this patient, it is imperative that we know that we are within target and our INR is between 2 to 3 as recommended. So in my view, I haven't seen any study looking at this, but I would think that in such a case, a VKA would probably be ideal. Thank you.
Perfect. Thank you very much. Again, question have been taken in the absence of Dr. Ajikum, but I think well answered as well. Last probably question at this point in time, so that we can be able to also to close the meeting, which I think has been very nice and very exhaustive and very scientific, I would say, from the presentation perspective. Probably we'll take this last question and then we can be able to close at this particular point in time. So, but this question goes to Dr. Mugisha. In thanks for the presentation. Please, what's the role of pre-referral prophylaxis in patients with lower limb fracture? In clinical practice, you see patients with fracture of the lower limbs in different degrees, and referral of these patients becomes problematic, either due to funds or referral pathway challenges. In those cases, is there a need for prophylactic anticoagulation, and which anticoagulant will you recommend? That's a question from Luluvi.
Yeah, thank you very much, Dr. Lear. I think the question is whether we need prophylactic anticoagulation in patients who have fractures in general, especially before referral. So as I said, in orthopedic practice, the Caprin score is the most important guideline in individualizing patient care with respect to venous thromboembolism. So we really need to score patients, even at the lower levels. I mean, all doctors need to know, including GPs, including specialists, need to know the Caprin score so that they quantify the risks, and especially those who are at high risk of venous thromboembolism should have undergo thromboprophylaxis. So, for example, in hip fractures in an elder patient, such as above 60s, that's a high risk already. The score is more than 5. So in that case, the patient needs both mechanical, that is, the patient needs to be as mobile as possible under physiotherapists and under orthopedic surgeons. The patient needs to be moved, bed ambulation, out of bed ambulation when possible. Although in acute fractures, that is very almost impossible in acute fractures. But on top of mechanical prophylaxis, you need pharmacological prophylaxis, of which in hip fractures, the indicated molecule is low molecular weight heparin. But what if you have a patient who has a hip fracture, an elderly, and who had previous or other risks, such as obese? So a patient who has a score of 9 and above, that is extreme high risk. After fracture fixation, even after referral, that patient will need extended thromboprophylaxis. That's when the DOACs come in. So otherwise, the ideal molecule in a patient who is inpatient is heparin, low molecular weight heparin. And once you need extended thromboprophylaxis, this is when the DOACs, including the Rivaroxaban, come in for at least 35 days in extreme high risk. But in a low risk, low to moderate risk, then you may need a short course of about 2 weeks thromboprophylaxis on Rivaroxaban. Otherwise, low molecular weight heparin still has a role in inpatients and polytraumatized patients or in patient fractures. Thank you.
Thank you very much, Dr. William Mugisha, for that response. I think at this point in time, it's getting late. And I would say, I think we've been able to achieve the objectives of the meeting today, which was excellently executed by our 3 experts in their respective fields, particularly Dr. Ajikum, speaking about Rivaroxaban, atrial fibrillation with a focus on Rivaroxaban, Professor Jane speaking about pulmonary embolism with a focus on Rivaroxaban, and finally Dr. William Mugisha speaking about Rivaroxaban in surgery. So I think, thank you very much for the well-executed presentation, fully scientific, fully educational, and I think quite beneficial in terms of what our partners and our doctors will be able to do and use in our respective countries. I also would like to extend our sincere appreciation to our guests and audiences from both Ghana and Tanzania. This is really, really appreciated, at least from a Fosun Pharma perspective. Varosun is a product which has recently stepped into the African continent from Fosun Pharma, and a lot remains to be done from a publicity perspective. But of course, this is a very starting point. I would call it, this is the launch of Varosun in Africa, the first launch which just occurred today. So really, really many thanks for your attendance and for your participation excellently through the many questions which were put on the chat box and on the Q&A sections, as well as on the comment section. This product, or this brand, Varosun, is available in Ghana and Tanzania, as I've mentioned. So as soon as you're able, and whenever you need to prescribe a brand of Rivaroxaban, always remember to think and choose Varosun from Fosun Pharma. I think at this point in time, I would like to say thank you once again, and wishing you the very best in the remainder part of your day, and a good night for East African colleagues, particularly in Tanzania and Kenya. Thank you very much, and enjoy the rest of your day in Ghana.
Tridem Pharma, a Fosun Pharma company, acting as an expert interface between the pharmaceutical industry and the African and European market, like health authorities, wholesalers, prescribers, and pharmacists. Dedicate ourselves to provide efficient, secure, and traceable global supply chain solutions. With all-round recourse support by Fosun Pharma Group, we have set up an one-stop, end-to-end closed loop of pharmaceutical services, from access to delivery. A professional team handles drug registration, warehousing, distribution, and promotion activities. Regulatory support at every stage of a product's life cycle. End-to-end warehousing service including flexible storage, picking and packing, and real-time KPI reporting. The application of a MedLink intelligence system realizes the visual tracking of the whole process. Warehouse in Toulouse, France. Opened in March 2024, support the special distribution of temperature-sensitive products, such as vaccines and biosimilar.
Hello.
A network of smart satellite warehouses, covering Côte d'Ivoire, Kenya, and other countries. A field team of 600+ experienced medical representatives, who are continuously trained on clients' products. Set up one-on-one meetings with physicians and pharmacists, and take orders on behalf of Tridem Pharma's clients. A multi-level system covering hospitals, pharmacies, and wholesalers with administration and hosting support, localized compliance, finance, and other services. Integration of industry resources has established strategic cooperation with more than 30 international pharmaceutical companies, in-depth partners of multiple international institutions. We have built an ecological network of the pharmaceutical industry covering commercial resources and public welfare actions, and promotes the efficient integration and sustainable development of medical resources.
Health is the eternal pursuit of mankind. At Fosun Pharma, we never stop innovating. Together, we're committed to creating better health for families worldwide. Founded in 1994, rooted in China and serving the world, Fosun Pharma is a leading innovation-driven global healthcare company. Guided by the strategy of innovation, internationalization, intelligentization, and integration, Fosun Pharma is committed to addressing unmet clinical needs through innovation, advancing the high-quality development of China's pharmaceutical industry, and contributing to global health. Innovation is the core driving force for Fosun Pharma's development. Backed by more than 30 years of exploration, Fosun Pharma has established an open and global innovation and R&D system. We are focusing on core therapeutic areas such as oncology and immunoinflammatory, and strengthening our antibody, ADC, cell therapy, and small molecules core technology platforms. Fosun Pharma has launched a number of breakthrough innovative products in the areas of breast cancer, lung cancer, hematologic malignancies, oncology support care, etc., and is actively expanding its pipeline in non-oncology and vaccine areas. In collaboration with industry funds, Fosun Pharma is investing in cutting-edge technologies, including radiopharmaceuticals, RNA, gene therapy, and AI drug discovery, continuously driving the development and commercialization of innovative technologies and products. Internationalization is a long-standing strategy and a core strength of Fosun Pharma. Fosun Pharma continues to execute on global strategy across R&D, licensing, manufacturing, and commercialization, striving to bring high-quality, innovative products to patients around the world. We continue to strengthen our global two-way licensing cooperation and expand the global market together with our partners. At the same time, leveraging our global presence, we introduce advanced technologies and products into China, accelerating localization and benefiting Chinese patients and customers. Since our founding over 30 years ago, Fosun Pharma has consistently upheld its original intention of contributing to society, actively embraced corporate social responsibility, and achieved remarkable ESG results. We support rural doctors and contribute China's solutions to the global fight against malaria. We care for rare disease patients and support innovation in China's life sciences sector. Looking forward, Fosun Pharma will continue to drive innovation and pursue global development with the ambition to become a leading global healthcare company to integrate the pharmaceutical and medical innovation, making greater contributions to human health. Innovation for good health.
Tridem Pharma, a Fosun Pharma company, acting as an expert interface between the pharmaceutical industry and the African and European market, like health authorities, wholesalers, prescribers, and pharmacists. Dedicate ourselves to provide efficient, secure, and traceable global supply chain solutions. With all-round recourse support by Fosun Pharma Group, we have set up an one-stop, end-to-end closed-loop of pharmaceutical services, from access to delivery. A professional team handles drug registration, warehousing, distribution, and promotion activities. Regulatory support at every stage of a product's life cycle. End-to-end warehousing service including flexible storage, picking and packing, and real-time KPI reporting. The application of a MedLink intelligence system realizes the visual tracking of the whole process. Warehouse in Toulouse, France. Opened in March 2024. Support the special distribution of temperature-sensitive products, such as vaccines and biosimilar. A network of smart satellite warehouses, covering Côte d'Ivoire, Kenya, and other countries. A field team of 600+ experienced medical representatives, who are continuously trained on clients' products. Set up one-on-one meetings with physicians and pharmacists, and take orders on behalf of Tridem Pharma's clients. A multi-level system covering hospitals, pharmacies and wholesalers with administration and hosting support, localized compliance, finance and other services. Integration of industry resources has established strategic cooperation with more than 30 international pharmaceutical companies, in-depth partners of multiple international institutions. We have built an ecological network of the pharmaceutical industry covering commercial resources and public welfare actions, and promotes the efficient integration and sustainable development of medical resources. Tridem Pharma, a Fosun pharma company, acting as an expert interface between the pharmaceutical industry and the African and European market, like health authorities, wholesalers, prescribers and pharmacists. Dedicate ourselves to provide efficient, secure and traceable global supply chain solutions. With all-round recourse support by Fosun Pharma Group, we have set up an one-stop end-to-end closed loop of pharmaceutical services, from access to delivery. A professional team handles drug registration, warehousing, distribution and promotion activities. Regulatory support at every stage of a product's life cycle. End-to-end warehousing service including flexible storage, picking and packing and real-time KPI reporting. The application of a MedLink intelligence system realizes the visual tracking of the whole process. Warehouse in Toulouse, France. Opened in March 2024. Support the special distribution of temperature-sensitive products, such as vaccines and biosimilar. A network of smart satellite warehouses, covering Côte d'Ivoire, Kenya, and other countries. A field team of 600+ experienced medical representatives, who are continuously trained on clients' products, set up one-on-one meetings with physicians and pharmacists, and take orders on behalf of Tridem Pharma's clients. A multi-level system covering hospitals, pharmacies and wholesalers with administration and hosting support, localized compliance, finance and other services. Integration of industry resources has established strategic cooperation with more than 30 international pharmaceutical companies, in-depth partners of multiple international institutions. We have built an ecological network of the pharmaceutical industry covering commercial resources and public welfare actions, and promotes the efficient integration and sustainable development of medical resources. Tridem Pharma, a Fosun pharma company, acting as an expert interface between the pharmaceutical industry and the African and European market, like health authorities, wholesalers, prescribers and pharmacists. Dedicate ourselves to provide efficient, secure and traceable global supply chain solutions. With all-round recourse support by Fosun Pharma Group, we have set up an one-stop end-to-end closed loop of pharmaceutical services, from access to delivery. A professional team handles drug registration, warehousing, distribution and promotion activities. Regulatory support at every stage of a product's life cycle. End-to-end warehousing service including flexible storage, picking and packing and real-time KPI reporting. The application of a MedLink intelligence system realizes the visual tracking of the whole process. Warehouse in Toulouse, France. Opened in March 2024. Support the special distribution of temperature-sensitive products, such as vaccines and biosimilar. a network of smart satellite warehouses, covering Côte d'Ivoire, Kenya, and other countries. A field team of 600+ experienced medical representatives, who are continuously trained on clients' products, set up one-on-one meetings with physicians and pharmacists, and take orders on behalf of Tridem Pharma's clients. A multi-level system covering hospitals, pharmacies and wholesalers with administration and hosting support, localized compliance, finance and other services. Integration of industry resources has established strategic cooperation with more than 30 international pharmaceutical companies. In-depth partners of multiple international institutions. We have built an ecological network of the pharmaceutical industry covering commercial resources and public welfare actions, and promotes the efficient integration and sustainable development of medical resources.